Good morning, everyone. I welcome you all to the Endo Mastery Summit, Apex Ascent, Mastering the Pinnacle of Endodontic Precision, a 2-day online conference on mastering the endodontics, organized by CynoDent, Indian Society of Dentistry, and Universal Institute of Advanced Health Sciences and Research. Today, on day one, starting with our first lecture by Dr. Nisha Dalal. She is the founder and owner of Nova Dental Care Thane, and topic for the lecture is the pulp biology, pathology, and why some endo works and some fails, from pain to plan, mastering diagnosis, pulp testing and case selection, medical history, risk assessment, and endo safety. We welcome you, ma'am.
Hello,
Yes, ma'am.
am I audible?
Yes, ma'am, you are audible.
Yeah, good morning, everyone. All right, so I'll just share the presentation. Give me 2 minutes and then we'll
Sure, ma'am.
initiate it. Okay? Yeah.
Sure, ma'am. Sure.
Is the screen visible?
Yes, ma'am, it's visible. You
The
can do it in
presentation is on,
slideshow
right?
view.
All
Yeah,
right,
yeah.
all right. Yeah. All right. So, the topic for today, the first topic is just a second. So, the topic for today, the first topic is going to be the foundations that actually work, right, in endodontics. We'll discuss the basics, that is pulp biology, pathology, and why some endodontics works and some unfortunately fails. We'll go ahead with the conditions that are mostly visible in clinical practice and understand how we go about diagnosis, testing of the pulp, and selecting the case, and then a few tips and tricks that I have learned in my journey as of now. And yeah, I am sure this will be of a lot of help to you guys. So one thinks of pulpal pain as the most common symptom of the pulpal pathology, right? Mostly patients are going to visit a dentist when mostly there's going to be some kind of pain or discomfort to the tooth. But this is not always true. There are many conditions that can lead to pulpal pain. And now let's classify the pulpal pain into the broad three categories. The first being the hyperreactive pulp, the second is the acute, and third is the chronic condition. This session is mostly going to be a bit of a clinical uh, approach where I'm not going much into theory. We'll discuss what happens for each condition so that you're quick enough to diagnose the case and reach to a probable treatment plan, right? Um, so we've learned in theory that there's reversible and irreversible pulpitis, but we are not going ahead with the histology, right? When the patient comes in, so it's mostly the patient history. Um, Whatever cases you've been doing so far, it will all help you. It will all compound, and it will be best for the next patient that you are going to have a look at. So you will be that quicker in analyzing that this might be reversible or this is something which needs endodontic treatment. So the more number of cases you look at, the more x-rays that you will see will definitely compound into something where your diagnosis is really great. And this is a topic which we usually overlook because we feel that diagnosis is a cakewalk. But trust me, when I say this, there are many cases where the diagnosis is not proper, and sometimes the patient has been, we've been able to save pulps and teeth which were initially planned for root canal treatment. And as an endodontist, um, I would always want to prevent going ahead with the endo treatment if the pulp can be saved. So that should be our first goal. If it is not required, we don't enter the pulp, right? So the three different categories or the broader categories are going to be the hyperreactive state, the acute condition, and then there is the chronic one. Now coming to the pulp. Um, as you all know, it is something which is confined within the rigid dentine walls. It is very rich in vascular supply, right? There's no collateral circulation. All these things kind of lead to the fact that pulp is not able to heal itself after a certain point, right? Um, the definition by Selzer and Bender is dental pulp is a delicate connective tissue which has tiny blood vessels, lymphatics, myelinated and unmyelinated nerves, and undifferentiated cells. This is something which we've seen drawn in histology in BDS, right? There are these four zones in the pulp, which is going to consist of your odontoblastic zone, which is responsible for the dentine. Then there's the cell-free, the cell-rich, and the pulp core, right? Uh, the odontoblastic zone is the one which is going to form dentine, and this helps in conditions where when you go ahead with treatment plans like pulp capping, this is the zone which is going to create that reparative dentine which will save the tooth, right? Then there's the cell-free zone, the cell-rich zone. The cell-rich zone is mostly going to have all these undifferentiated mesenchymal cells and the connective tissue cells, and also the cells of the pulpal core. Then coming to the nerve supply. Nerve supply is by the branches of your maxillary and mandibular divisions of the trigeminal nerve, right? And these are the two broader things that you need to keep in mind, that the plexus of Raschkow, which is present in the pulpal core, it is going to contain myelinated A delta fibers and the unmyelinated ones, which is the C fibers. So the A delta fibers are the ones which are going to be responsible for, what are they responsible for? Anyone? Yes, I can see nine participants. I need an answer. we'll keep it interactive because otherwise it will just be a single session. What are the A delta fibers responsible for? Students, am I audible?
Yes, ma'am, you are audible.
Yeah, okay, I can see it in the chat. Yeah,
Is responsible for fast and sharp breaking pain.
correct. Yeah. So mostly if that is something which is that kind of a sharp and shooting pain, mostly you might find that patient coming to the clinic because it is a really bad pain. And if you have been, as a dentist, if you have been through something like this, you know what I'm talking about. It's a really bad pain. And usually the patient is not going to be able to bear it, correct? So that is the A delta fibers. Then there is the C fibers, which are responsible for the slower, diffuse kind of a pain. It's more of continuous gnawing type of pain, but something where the patient will, might ignore it and still, go ahead with his life, right? So these are the two distinct fibers that are present in the pulp. The broader functions of the pulp include the inductive, the formative, the nutritive, protective, and the defensive ones. I'm not going into detail about the functions as you all know what they all are. Yeah. So coming to the first uh, condition, that is the dentinal hypersensitivity, right? In the absence of inflammation, hyperactive pulp or dentine sensitivity, it is the mildest form of pulpal discomfort. Now, here the pain is going to be characterized by a very sharp, short pain. It's brought by something like heat or cold or anything which is acidic, like lemon, and it's never spontaneous in nature. So, if there is someone who's coming and telling you that, look, I have pain, but I have it only while I have something. Other than that, I'm fine. Your diagnosis goes towards indication of something where the pulp is doing fine, but it is getting irritated because of the stimulus that is coming in. So usually with ice creams or things like that, the patient will find discomfort. So. Here what happens is, can anyone tell me what happens here when, for example, if there's someone who's having ice cream and there's some triggering happening, what is it that is going on with the tooth? What does it involve? Like, what happens? Like, any idea, any input from you guys? So it is going to cause fluid flow, correct? In the tubules. You know this? There is dentinal fluid in the dentinal tubules. Hello, am I audible?
Yes, you are audible.
Yeah. So it is going to cause dentinal tubule fluid flow, which is going to cause that compression of the nerve endings, and that is going to irritate the pulpal nerve, correct? And that is why that sensation of a very sharp, hypersensitive reaction will be produced, correct? So this is called dentinal hypersensitivity, right? So in this diagram, it's just a Pictionary way of where the cold stimulus is applied on the pulp, and that is causing the fluid to contract inside the tubule, right? And because of that, the tubule contains the nerve inside it. So that is now going to get irritated because of the fluid movement, and that to a sudden fluid movement, right? And that causes a sudden intense pain that is experienced. So the treatment can be, there are several forms. Initially, we used to go ahead with insulating bases like zinc oxide, eugenol, and all, where you just block and occlude the tubule, and the fluid will decrease, the fluid flow will decrease. But now with great dentine bonding agents, we can just remove the smear layer and then coat it with a dentine bonding agent, which will really improve the fluid, I mean, the sensitivity aspect of it, and decrease the fluid movement, right? But before we seal the dentinal tubules, it's very important that uh, we have removed the smear layer using EDTA. Have you used EDTA ever in cases, and have you seen the effect of it? Anyone? So basically, EDTA is something which you must have heard when we use it while disinfection of the root canal treatment. The canals get disinfected, and then we wash it with EDTA liquid. So that kind of opens up the dentinal tubules, and then the sealer is now going to penetrate into the tubules. So similarly, we can scrub the dentine with EDTA, wash it with saline, and then go ahead with using your bonding agents. So that will have a much better long-lasting effect. Coming to the next condition, that is acute pulpal pain. So there are three types in this again: the incipient, moderate, and advanced ones. It's all got to do with the level of inflammation that is present. Some patients might report slight discomfort, maybe because of caries, or maybe because of some trauma, or maybe because the patient has had a recent restoration and has some discomfort. On radiography, it will disclose a incipient carious lesion, and if there is some trauma, PDL thickening might be visible, but usually happens at a later stage. So go ahead with your pulp testing. Cold testing is the best, and so once you've done the cold testing and once you know that the pulp is normal, you can just remove the stimulus. That is, if it's initial caries, we can go ahead, remove the decay, close and seal the tubules which are exposed, and the tooth will be fine. If it's something got to do with a high filling that the patient has received earlier, we can just remove those high endpoints and cause relief. So in this image, you can just see the image number A, where the caries is the reason why the patient had pain. And in B, if you see, the arrows demarcate here that there has been some kind of a reaction as well from the caries, and this is kind of going ahead to a moderate side of the pulpal pain, right? The moderate pulpal pain, it is something called, it is described as a boring or a nagging type of pain. This is extended pain, and it's diffuse and hard to locate. So if the patient comes in and is usually moving his finger across 2 to 3 teeth, it might be because he might not be able to locate from where the pain is getting initiated. So cold may be one of the irritants that starts the pain, but hot food or drink and biting down are also reasons for it, right? If in this condition you go ahead with vitality, if the pulp is vital, great, we can go ahead and save the tooth with pulp capping procedures. But if there is irreversible pulpitis, then we might have to remove the pulp. Painkillers will help in such situations, right? So in this case, yeah, this was the further cause here. Now there's a bridge given here in this case, and the underlying secondary decay has caused the pulpal pain, which is happening in the premolar. So we'll have to go ahead with the root canal in this premolar. In the event of moderate pulpal pain, it's mild and of short duration, and you have to go ahead, remove all the caries under rubber dam, and a calcium hydroxide dressing might be placed with a temporary material. Once the symptoms decrease, then we can go ahead and obturate the tooth Sometimes, if there is no pain, if the radiographic and clinical signs permit, we can go ahead with a single visit obturation as well. Advanced pulpalgia. It is the ultimate toothache. So this is the last condition. It's a very excruciating sort of pain. It is totally irreversible pulpitis. So here now we have to remove the pulpal tissue or the necrotic tissue which has now been present there. The relief of this pain is embarrassingly simple cold water that is going to relieve pain. So at times patient might tell you that the cold is now helping the pain to subside. The tooth will be responsible to percussion. Diagnostic radiography is not very relevant in such cases. And so you can go ahead with a local anesthesia, a block, and then initiate access opening and biomechanical preparation. But just one thing, when we are examining such patients, and if already the patient has told us that there is severe pain, try palpating the tooth and avoid percussion of the tooth because that creates a lot of pain and we don't want that, right? So the only solution here is, as we are an endo, I don't want to talk about removal. But if the tooth is not salvageable, then that is the last option. But we would want to save the tooth by pulpal removal and root canal treatment. If the socket is risen, which is in most of the cases, go ahead, give the block, and then first step should be to remove all the high end points. That is, occlusion should be relieved. So that will help when the patient comes to you in the next appointment. And once you initiate the access opening, make sure you have located all the canals so that you are not missing out on any pulpal tissue that is present in the root canal system. Enlarge it with a number 15 to number 20K file in the initial appointment, and then you can go ahead with the shaping and cleaning procedures in the next appointment. But enlarging it till 20 to 25 number will ensure that most of the pulpal tissue is out and patient will be relieved in the first appointment itself. Now, chronic pulpal pain. This is also complete irreversible pulpitis. That is a kind of a grumbling pain and discomfort, but it's not very excruciating or sharp because it's become chronic in nature. Usually, you'll see cases where there is a very large cavity that is present and a very open sort of a cavity, so that there's no pressure buildup that is happening, and there is a diffuse kind of a pain. So patients usually admit that they've been having analgesics or antibiotics since someone prescribed, and they've just not gone ahead with the treatment, and they've just taken it out on themselves. And the pain, because that is the kind nature of pain, it's very mild enough and it's very diffuse, and it might also refer to other teeth or to the opposing arch, right? Cold is going to have little effect. Heat will be the main thing here, which will cause the discomfort that will be present. So when you go ahead with access opening, once you've done the rubber dam isolation, given block isolation, and started the access opening, you will see that there's mostly the necrotic tissue that is coming. These cases are very easy to uh, visualize because there's not much of bleeding that is happening. You can clearly locate the canals, and the tissue also comes out in a very dark maroonish type of a manner, and you can just visualize the cavity very nicely, right? Because most of the tissue has now undergone necrosis. So you will be able to diagnose this case a bit easily than the reversible side of the pulpitis, because there is generally one single pinpointing tooth that the patient will touch and show. And also, sometimes in such cases, the periodontal ligament gets involved, and so it becomes easy for the patient to pinpoint to that area. And yeah, that is how it's a little bit easy as compared to the sensitivity or reversible diagnosis. the electric pulp tester records a very high reading. Why is that? Can anyone let me know? Why is the electric pulp test now going to give you a very high reading, or the patient will be able to withstand it? Yes, anyone? You can just attempt. It's fine. We can just have a discussion. Why do you think that the electric pulpal testing is going to show you a very high reading, or even after it crosses the higher limit, the patient doesn't feel anything?
Normally, this pulp fluid becomes necrotic, so it is not vital.
Right, right. So there's no vital tissue left, correct? So there's going to be no response, because as we saw, there were so many layers of the pulp and it's now all destroyed, right? So we don't have any kind of a response from the patient. But if it were to be something where the pulp is vital, I would patient would just raise their hand and just tell us to stop it, because the pulp is intact, it's vital, it's just inflamed in nature, and that is the reason why we will have a response, right? So in such cases, electric pulpal testing, or for that matter, the cold testing, you won't be able to have any kind of a response from the patient. Correct? Radiographic evidence is going to be helpful here, where you will see a big chronic carious lesion and also a very well thickened apical periodontal ligament. It might also be accompanied with some bony reactions that might happen, and some kind of a root resorption. So once you go ahead with the root canal treatment, and after 6 to 8 months, if you are lucky enough that the patient shows you a follow up, you will be able to see that the bony reactions that had happened in the pre-operative X-ray have now gone away, right? So the treatment of choice is a root canal treatment. You go ahead with access opening, working length determination, cleaning, shaping of the root canal system, and then obturate it once all the symptoms are done. Necrosis is the last stage where the pulp is now completely destroyed and devoid. Okay, it is mostly infected. Necrosis can be because of two things, right? First is caries, most common cause of necrosis, but necrosis will not happen quickly if it is due to caries. It will take some time. The pulp will go through uh, the initial stages of inflammation, hyperreactivity, and then if it is being ignored for a very long time, then the pulp will die a slow death. But if it's something got to do with traumatic experience, then yes, the pulp will die quickly. So you have to understand the cause of the necrosis here. It can be due to caries or trauma. So this is the histological photograph, where if you see in the white arrow, these are the micro abscesses that have formed, right? That is because the pulpal tissue has died a slow death. And here, these are the clumps of bacteria and necrosis again. So again, pulpal testing is an accurate way to prove necrosis. If there's a full crown present, it is very difficult to go ahead with testing of the tooth. And if we have to go ahead with a re-root canal or endodontic treatment, it is ideally best to cut out the crown and then start the treatment. So once the prosthesis is out, then we will go ahead with the pulp testing procedure. Otherwise, you might have some false responses as well. Okay, same as that of chronic irreversible pulpitis. Your pulpal necrosis, the solution is to remove the pulpal tissue, disinfect, shape, clean it, and then obturate it. Just make sure that you are not causing any extrusion of infection. This is not only something that you have to remember in necrosis, but also in other cases where you have to prevent extrusion of infection outside the apex. That can be done by preventing wedging of the file beyond the apex. Slightly pre-curve the file, a 10 number file, and you can slowly work your way through till the apical foramen, but don't push the debris there. Otherwise, this will cause a post-operative discomfort. Okay. Now, in this case, what do you think? What would be your diagnosis, or what would you think if you just see the radiograph? The one here, if you can see, if I were to just give you the radiograph, what would you feel? What is it? Yes, there's a lot of bony changes that are happening, right? If I were to find this radiograph, I would feel that this is something got to do with trauma, or these teeth have lost vitality, and that is the reason why so much of lucency has happened, correct? But this condition was a condition known as osteofibrosis, where fortunately all the four incisors had vitality. And the pulpal testing, this is where you understand that if I were to see this radiograph and have had no history, what the patient has had, or had no pulpal testing, I would have straight away gotten root canal for all these teeth done, correct? But that was not the case. This was a case of osteofibrosis, and all the teeth were vital. So, pulpal testing is very important when it comes to treating and diagnosing. Also, pulpal pain is notorious for its referring nature. So, you have to make sure that when the patient is pinpointing to a certain region, you also need to check the other area. So, full mouth examination should be done. Correct? So, upper to lower premolars or maxillary to mandibular molars. Now, usually the upper incisors might also refer the pain to a frontal headache, or the pain from the lower molars will radiate towards the ear and also the jaw of the patient. So this is something which we have to take care in mind. Fortunately, what happens is this pain does not cross the midline, right? So that is a good way to understand. If a patient is going to insist of having a lower molar pain, and yet all the testing and examination of that area is negative, so you go ahead and test the opposing molars. If there appears to be a cause for pain in the arch, but no pain is felt there, then we have to go ahead with the anesthesia technique, where we will anesthetize one arch and then understand whether the pain is coming from that arch or not. There's something also called as atypical odontologia. I personally myself had this kind of a case where there was a patient who had a lot of pain when it came to the neck and to the lower jaw and the occipital part of the region. And the patient had several teeth that were also needing dental treatment. So, our first diagnosis was obviously the pain is due to the teeth that are involved. But after treatment, also, the pain was not going away. So later, we sent the patient to a neurologist, and we understood the patient had a slight form of depression. So you see, this is something which we will never think about, right? We are always mostly focused on the oral cavity or the pain related to teeth, but having an idea that such conditions can also trigger painful experiences related to the oral region is very important. That is, so your over 80% of the patients are female, and usually also the dental treatment that the patient has might also trigger something like this. So in this cases, tricyclic or monoamine oxidase inhibitors or antidepressant therapy is going to help relieve the pain. This is a very different aspect. We mostly don't think about it because our diagnosis is mostly whether it's a reversible pulpitis or irreversible one. But there are other conditions of the head neck region which might also trigger painful responses. Okay. Also, the extraoral pain references coming from the heart. This is something which we ought to know. It's myocardial infarction or thrombosis or angina, right? The patient might present with a typical toothache and then uh, uh, usually the left jaw, right? But it might be something related to angina or chest pain. So we have to take a thorough medical history of the patient and be aware that whether this is the reason why the patient is having any pain. Yeah. The next condition is internal resorption. Here, it can sometimes you can see a pink tooth, or it can be usually an unexpected form of a radiographic discovery, right? Usually, what is the reason for internal resorption? Can anyone tell me? What is the most common reason for the resorption that initiates? Is it dental caries? It's usually trauma. Okay, some form of trauma. It can either be due to ortho treatment as well. If the forces are too much for the tooth, the tooth can start having internal resorption where there's destruction of dentine. Your odontoblastic layer is now getting converted into the dentinoclastic type of cells. So here also the treatment is we have to go ahead, remove the pulpal tissue, remove all the clastic cells, and complete the root canal treatment. These are some images. Here, in this case, okay, the radiograph you can see here. These teeth were prepared for receiving a crown prosthesis, but the dentist had not used enough air water coolant. And see, it is a very sad state of affairs where now there's such a huge resorption that the teeth might not be salvageable, right? So these are also some of the reasons why resorption can happen. Now, tooth infarction, it is a very tricky thing to diagnose. If you are able to diagnose it in the first go, it's a great thing. Sometimes you might do many things and still not realize that it was because of a tooth infarction. Tooth infarction, also called as cracked tooth or split tooth syndrome, it is going to involve splitting of the two parts, which are yet not separated. So the easiest way for the treatment plan is if the crack is not extending into the pulp, okay, we do a crack dissection, and till the crack is visible, we are going to remove it and restore it. If a full crown is needed, we might have to go ahead with that. But if the crack involves the pulpal part of the tooth, then invariably it was also infected with bacteria because the bacteria will seep in through the crack. And so we might have to do one endodontic treatment and then go ahead with the prosthetic part, right? So the diagnosis is either you can use your very fine explorers, um, dry the tooth, look under, use magnification, please. It will really help because such cases are very difficult to diagnose under the normal light. So magnification will help. If you've got the dyes like iodine, if you can just use a bonding agent brush and just applicate a tip and just place the dye over the crack and then wash it after like 2-3 minutes, the crack will kind of absorb the dye and you will be able to discern it. Also, pulp testing will help whether to just to have an understanding whether the pulp is involved because of the crack or not. Tooth sleuth is one of the examples where you can use that, or you can, in clinical scenarios, go ahead with a cotton roll and ask the patient to bite. Radiography, radiography at times might, if you are lucky, if the fracture line is in the path of the X-ray beam that you're shooting, it might be visible, but you might have to take 2-3 angulations in order to discern whether the crack is present, right? So here's the example. Yeah. Coming to periapical conditions, apical periodontitis, as we all know it, it is classified as symptomatic and asymptomatic. So, symptomatic apical periodontitis has a lot of the intensity is similar to that of the advanced pulpal pain. Okay, maybe a day or 2 day for 2 days the patient might have keep having pain. And what is present in the periodontal ligament that the patient is able to pinpoint the tooth? Can anyone let me know? How is the patient able to pinpoint the tooth uh, vis-a-vis the cases where there is pulpal pain, where patient is not very clear as to which tooth is the reason for pain? Because of proprioceptors that are present, right? The proprioceptors will help the patient to pinpoint that this is the tooth that is causing that kind of a pain. Violent inflammation develops here because now the pulp is infected and the it has now reached the periapical region. Also, the reason for that kind of pain is because the cortical bone is very confining, right? It's not going to let it pass through. And that is the reason why there is no room for any fluid expansion. The pressure is going to increase, and that will uh, really intensify the pain. The pain is usually gnawing in nature, throbbing and gnawing in nature. So again, here when we are trying to test the tooth, if whether it is infected, not infected, percussion should be done with a lot of care. Just don't take your probe and start banging the tooth because it is very hurtful. Just first palpate it with a gloved finger, and you might not be even need percussion. You may just understand that this is a painful kind of a response, right? So here we might have to need give a long acting block anesthesia like bupivacaine. Then once the tooth is numb, go ahead with your rubber dam placement, or you can even do something like excavate the caries, open the axis, and then place a rubber dam so that you might not go ahead and do a iatrogenic error, right? I do that where I have removed all the caries, I have opened the axis, and then I place the rubber dam so that it's easy for me to complete the cleaning and shaping procedures. Once you have done the rubber dam placement, then an access opening has been achieved. Locate the canals, and here, because there is infection which is trapped below the tooth, right? Just with a slight 10K K file, you pre-bend it, and you have to go a little bit beyond the apex so that the pressure and the fluid that has been trapped below the root apex will get relieved. Don't shove the file, but very small watch winding in a watch winding way. Just go till the apex, a little bit beyond, and then come back. Right. Um, Again, like I had mentioned in the previous case, enlarge it for till 20 or 25 so that all the pulpal debris will come out, and then you can uh, close it with a dry cotton pellet and a filling. Do you think open dressing is something that might help here? Have you heard of this concept of having an open dressing? Anyone? Usually, open dressings are given cases of swelling or a lot of pain, but nowadays it is frowned upon because it might cause reinfection, and the cotton pellet might not be able to just wave off that infection. So, you can place the cotton pellet in the chamber, ask the patient to sit for around 15-20 minutes in your operatory, and then once again after saline irrigation, you can place a temporary. But don't go ahead with the open dressing as it might complicate the case further. Now, acute apical abscess. This is a periapical extension of the canal necrosis where the bacteria is going to have a very overwhelming resistance and there's going to be severe inflammation and pus formation. Here you will be able to appreciate a swelling that is present. Yeah, as the abscess will become hardened, the patient will experience more pain. But if the abscess is more fluctuant in nature, the pain is less. So, here the main idea is if you have a swelling and if you feel that this is the tooth responsible, if there is presence of sinus, go ahead with your 22% or 25% GP, place it through the sinus and take an x-ray. You will, so that you're sure that this is the culprit for the abscess. Just because the radiolucency is around a particular tooth, don't start the access opening of that tooth. Please check which tooth is responsible for that kind of abscess. So this is very important when it comes to abscess diagnosis, right? In early cases of abscess, it can get drained through the root canal by doing the access opening and cleaning shaping procedure. But if it is too much, if the abscess is beyond a certain extent, you have to urge the patient to go ahead with frequent hot rinses. So that will help speeden up the process of the pointing. And so once that is evident, you can do the incision and drainage of the abscess and complete the root canal treatment as well. Yes. Chronic abscess is something where the bacteria has low virulence and it's been there for a long time. So there will be a stoma or a draining abscess in the oral cavity. Similar like acute, but just the virulence of the bacteria and the patient's immunity have kind of created a situation where it is not causing a severe response. A draining fistula might be present on examination. So again, same like the acute abscess, a radiograph is needed with the GP helping us point out which tooth is the culprit. Pulpal testing is also important, like the case of necrosis. The tooth here is also completely necrosed. So you will have no response to any thermal or electric pulpal testing, right? So root canal treatment often is going to resolve the abscess problem. And once the fistula stops draining after the first appointment, then over a period of time, the abscess is going to get healed with and filled with newborn, but this will take 6 to 8 months for it to show on the radiograph. Yeah. Asymptomatic apical periodontitis. Now, this is a painless condition, often characterized by a radiographic appearance, and patients here might not even be knowing that they have something like this. If you go ahead and tell the patient that you need a root canal treatment, they might ask because there's no pain, right? Why do I need a treatment? Because there is no pain or any problem. So, in order to prevent any bacteremia or leaching out of the bacteria in the bloodstream, we can put it across in this way that there is a treatment that is required in order to prevent worsening of the situation, right? It is the asymptomatic apical periodontitis. It's revealed in routine radiography. And so again, pulpal testing is negative and percussion is of little value. If the lesion has been result of an accident and has been there for a long time, see, the patient is going to question why is the treatment necessary. So you have to give this reasoning that this might be a problem, especially for patients who've had any surgeries related to the heart. So that is how you will counter. Apical cyst. Now, apical cyst is a condition where the inflammatory process, which was happening all along in periodontitis, is now stimulated the epithelial resting cells of Malleus, right? And then they have created a cystic lining around the tooth. Here, in some cases have shown that after you have done the root canal treatment, there is healing, but most cases require a surgical approach where after the root canal treatment has been done, you curate the cyst, remove, disinfect, curate the cyst, and then refill it. Yeah, so this is a case, okay? Here, if you look at the lesion, this was a case which was diagnosed as periapical granuloma by the dentist, and then he went ahead and did the root canal for this premolar here. But later it was diagnosed as an ameloblastoma, right? And the patient had to get the mandible amputated. So make sure that X-rays, diagnosis, use of OPG is happening. Differential diagnosis are the one cases where there are lesions of the non-pulpal origin, and it can get misdiagnosed as endodontic lesions like carcinomas, sarcomas, cementoblastomas, or granulomas. So we need to make sure if it is not a very small cavity, a small lesion, go ahead with a OPG or a CBCT to help you come at a correct diagnosis, right? This is something which I had, these are the instruments for diagnosis. I have incorporated them in the uh, diagnosis part of individual lesions, and I'll just go through it. So basic diagnostic modalities we have is your mirror, your probe, and your um, radiography, correct? Other than that, other devices which will help you in diagnosis is the pulp testing. That is better, is going to be cold test. That should be one. And second is magnification. Okay, magnification will help you diagnose it really nicely. Okay, and if you are someone who is able to prevent a root canal treatment and do something where you have saved the tooth of the pulp of the tooth and the tooth with a filling or a restoration, or just avoided an unnecessary treatment, that patient is always going to show up at your clinic, because uh, people, more than we realize, people do want to save their teeth. They don't want to go ahead with unnecessary root canal treatments, right? So it's very important for us to have a proper correct diagnosis. Radiographic methods. So as you all know, it is the most valuable tool in endodontics, but we have to remember that it's a 2D image of a 3D situation that is going on. So ideally, take two angulated x-rays. For patients having some interproximal problems, please go ahead with a bite wing radiograph. You don't need a bite wing setup for it. You can just fold a paper along the sensor and ask the patient to bite in a way where you can see the interproximal areas, because how much ever you try to record the interproximal decay on the X-ray with a normal angulated method that we all do, you are never going to be successful. But bite wing radiography is beautiful, and it will really help you. Either it will help you understand how beautifully you've executed the restoration, or where there is overhangs or underfilling. So bite wing radiography is something that we should start incorporating, because I know we don't use bite wing radiography that much. So please go ahead and try. There are a lot of YouTube videos where you can just fold your sensor into a piece of paper, place it in the bite of the patient, slightly ask the patient to bite, and you get those beautiful interproximal areas. Okay. So along with two angulations, if there is interproximal caries, take a bite wing X-ray. Other areas, other details which we have to look. If so, when I'm talking about endo, follow the lamina dura of each tooth. That helps you understand the number of roots and the number of canals, and whether the apex is open or blunted or resorbed. Okay, so it is difficult at times, so try and use these methods of contrast and define it more, so that it will help you better. And the more you take x-rays and the more you read them, the better you will be, right? See, this is a palato-gingival groove which is evident on the x-ray here. So radiography, I don't think I need to mention how important it is. Pulpal vitality, I've already said there are three: thermal, electric, and thermal has two in it: the cold testing and the uh, heat testing, right? We have the spray, the cold spray, which just you use a small cotton pellet and place it on the tooth, and you can execute the, you can understand the response that the patient is giving. Patient, doctors or dentists might find it a waste of money to invest in a cold spray when they start with their clinical practice, but trust me, it is very important. Okay. Hot testing is something I don't do, just a theory part where you heaten up the GP and place it on the tooth. But yes, cold test is very easy, very quick, and very good response can be elicited from the tooth. Electric pulpal testing, I'm sure everyone has tried their hands on an EPT. There are a number of electric pulpal testers which are all like examples are vitality scanner, endo analyzer, digitest, gentle pulse, right? There's a lip clip and you have to place paste on the tooth which you want to uh, check the vitality for, and it gives the result. And first, before you start testing the tooth that is going to you in question, check the contralateral tooth so that you know what intensity of pain the threshold the patient has, and then go ahead with the testing of the tooth in question, right? But out of these three, the cold testing would be the best way to invest in a cold tester, so that will help you. So yeah, coming to the end, see, biology is the foundation of a successful endodontic treatment. And here, I will again reiterate: we feel that we know diagnosis, but I've had so many cases where diagnosis is something which was confusing us dentists, and there were either fractures or some J-shaped radiolucencies that we got to see after we executed the treatment plan. So, if you are really good in diagnosis, you are bound to have clinical success, right? So accurate diagnosis is the most critical step. And I, as a student, I myself used to just go ahead quickly with this topic and feeling that I know this. But once I have entered the clinical practice, I realize diagnosis is not how easy we feel it is. Understanding pulpal and periapical pathology guides appropriate treatment decisions. And also, success is going to depend on meticulous diagnosis, disinfection, and a sound restoration. So, after endo, just not doing a good endo, but doing a good sound restorative treatment over it is going to help the success of the tooth, right? So it's a great endodontics. It's not about treating canals. It's about understanding the biology, making right diagnosis, and delivering the right treatment at the right time, right? So with that, I conclude my session. I hope this was a helpful 1 hour session for you guys. If you have any doubts, let me know.
Any participant, if you have any query, you can ask.
Yeah. The treatment for trauma. Okay, someone has asked here. See, for trauma, first you understand what was the cause of trauma, correct? And I would first go ahead and try to relieve the occlusion of the patient, correct? And then check any if there is any soft tissue injuries that have happened to the patient, because when you are talking of trauma, there are several reasons why a trauma could have happened, right? So check for the adjacent areas of a trauma, and then depending on the type, so there is initial enamel infraction, say like it goes to avulsion, right? The treatment is going to completely depend on the type of trauma that you're talking about. So your pulp testing will not help here, correct? Why will it not help? Because it's recent trauma. You can't test the nerves. They are in a state of shock. So you can take an X-ray, you can do clinical examination, assure the patient, remove the occlusion, the high end points, and then patient can be called on follow-up. Correct? But mostly when there is trauma, usually the pulp has lost its blood supply and most probably might need endodontic treatment. But there are some cases where there is rejuvenation of the blood vessels and the pulp stays vital. Like in cases where there is middle third root fracture or apical root fractures, you don't have to do anything about it because the body takes care of itself. But regular follow up is needed, right? So that is which trauma is the part I am not understanding. But yeah, follow up and this will be important. Secondly, which GP for abscess? So if there is a abscess and there's a pinpointing stoma out there, use a 2% GP. Okay, 2%, any 2%, 20 or 25 number GP is what I have used, and that is something which slides in very easily. So you just place it and take the X-ray. So that GP will go to through the path of least resistance, and you can take the X-ray, and you'll understand that this is the tooth responsible for the infection. Ma'am, treatment of that case of yeah. This is the radiograph where there were 4 incisors, right? And there's a lot of radiolucency. So that was a case of osteofibrosis. Nothing got to do with endo or pulpal tissue. It is completely different. But if you look at the X-ray, you might feel that the patient had some fall, some trauma, and the pulp is now gone bad. It's become necrosed, and it is now showing up into the bone. But that is not the case. So this is something which I will never understand if I don't have any pulp vitality testing in my clinic available, right? So cold testing will make me realize that there is no pain when or there is adequate amount of response that the patient is giving me with that stimulus, and I will not touch the pulp. Yeah, for protocol for IPC, DPC, what I usually do is if it's an indirect pulp capping, right? You want to remove all the caries from the periphery. Okay. Recently, I've invested in something called as the caries detecting dye, right? You can use according to your budget. You can try different companies are offering different caries detecting dye. You can understand it by using many. So you just place it with your applicator tip. Make sure that the periphery of the tooth is completely devoid of the decay. And as you go near the pulp, you can just I mean, leave some slight amount of pink tooth structure that is caries infected by there, so that you don't open up the pulpal tissue. And after that, I personally have tried 2, 3 materials, but I like biodentine. So I place biodentine in that area, and over and about, I don't restore it in the first sitting. I go ahead and place a glass ionomer cement restoration. And if there is no pain or any sensitivity, then I will do a permanent filling restoration. But some people do it in the first go itself. They do the pulp capping and they have a final restoration in place on the same day. You can even think of that. It's all dependent on you. Uh, Ma'am, after RC and capping 3, 4 months, if it's sensitive to chew or biting, uh, what is the reason? Sensitive. If you're talking about that tooth, either there are many causes for this. Either this can be because there's some amount of secondary caries that was left behind. The post-obturation restoration was not done. Usually endo heals, okay? But the post-obturation restoration is something we all neglect. We avoid placing bands and wedges, and good isolation is, I don't know, we avoid it, overlooked type of a thing. But that is maybe that is the reason why you are having this. If there's some sensation or sensitivity, I might it might indicate some missed canal or some under preparation there. Okay. Treatment for only hot sensation. I didn't understand this question, Dr. Amit. Treatment for only hot sensation after PFM crown, as in?
Thank you, ma'am.
One, yeah, okay. There's one question. Can you just unmute yourself and just ask this, because I've not understood much um with this question, and then we can maybe start on with the next session. I didn't understand this question.
Good morning, ma'am.
Yeah, hi.
Actually, there was one patient which came in the OPD,
Okay.
and he was having a lot of severe pain.
Hmm.
And on percussion, there was TOP positive. But on
Okay.
radiograph, there was no problem seen, like no periapical radiolucency and all.
Hmm.
So one of my guide, she told like there is like a crack present. Like she was
Okay.
thinking of a crack. She saw the case. And
Right.
she asked me to reduce the occlusion and put the bonding agent in that crack and
Okay.
recall the patients like for review. Then after the first visit, the pain reduces.
Okay.
Then in the second visit, again we put the burning agent and the pain reduces more.
Okay.
And the third after the third visit, the patient came for the last time for the fourth one. Then he came with a broken tooth, like that crack it penetrated, and there
Hmm.
was a fully crack. What will
Yeah. Yeah, so maybe the bonding agent was just helping the fluid movement for time being, and like I said, the crack. It's very difficult to visualize it. Was this checked with magnification or with a dye? Was it possible at that point of time to do this?
no,
Um,
ma'am.
and also the X-ray. Okay, this can be deceiving with X-rays because there's such fine cracks, right, that are happening. So bonding agent must have helped for a while, but eventually the crack proceeded, and as you are saying, the patient came back with a fragment. So was the fragment where the pulp was involved, or just the enamel or dentine part was just broken?
No, ma'am, the pulp was involved, ma'am.
All right. So was a vitality done for this case preoperatively?
Ma'am, no, ma'am, ma'am.
Yeah.
That
So maybe if uh, a vitality would have been a little bit of help, but yeah, these cases are such, they uh, create problems. It is not very easy to diagnose on CBCT also. You need a certain amount of crack in order to get diagnosed, right? Beyond that, it's not possible. So yeah, maybe a pulp vitality test would have helped along with magnification, and then you would have realized that no, the pulp is involved here, and we need to go ahead with endo treatment, something of that sort. Okay.
thank you, ma'am.
Yeah. Okay. I think I've answered everything.
Yes,
The
ma'am.
more the more you look at X-rays, the more you understand that you know less. So you keep looking and keep reading more radiographs.
Thank you so much, ma'am, for such wonderful lecture.
Thank you.
Thank you, ma'am. Moving on to the next lecture of the day by Dr. Swapna. She is Associate Professor in the Department of Conservative Dentistry and Endodontics at Nirvana Dental College and Hospital, Andhra Pradesh. Ma'am is going to talk about axis, anatomy, and rubber dam, about the anatomy of the MB2, C canals, and tricky configurations, and about the isolation from resistance to routine in every operatory. We welcome you, ma'am.
Good morning.
Good morning, ma'am.
Can I share my screen, sir?
Yes, ma'am, you can please share your screen.
One second.
Also, I would request you to turn on your video while you are giving the lecture so that
Yeah.
student can interact with you.
Yeah, sure.
Okay, ma'am.
One second, I'm trying to share it. Can you see the screen?
Yes, ma'am, it's visible. Can we have the slideshow view?
Yeah, I'm doing that. Now it's okay?
Yes, ma'am. It's fine. We can start.
Yeah. Am I visible?
Yes, ma'am.
Yeah, good morning. Good morning to respected organizers, dear participants, and the faculty present over here. I indeed have a great opportunity to deliver this lecture, and thank you, CynoDent, for giving me this opportunity, and Perifurtured Academy and the organizing committee for providing to the knowledgeable platform to share all our experiences and knowledge to all. So before we talk about what the topic was, the main quote today was, what you see depends on how you look. So what my intention to keep this slide was the perception of how we see the x-rays. As ma'am said in the earlier, radiographs are most important diagnostic thing when you come to looking forward to your endodontic treatment. So the more you analyze your internal anatomy and more you give your radiographs more importance, then only the perception of looking into the case and into the tooth will change a lot. So before we going to actually talk about the handover of your files, obturation, irrigation, infection, and all, three phenomenon which are happening outside the canal plays a major role. So that is your rubber dam isolation and knowing the internal anatomy of your tooth and endodontic access. So you all know about this triad, that is endodontic pyramid. If you see this triad, it masters the different steps involved in the endodontic treatment. The first baseline foundation for the endodontic treatment was access cavity preparation. And then followed your working length, biomechanical preparation, master cone, and your obturation. But the baseline always happens to be the foundation is your access. When you do this correct, and all the steps that was followed will be correct. If you gone wrong in this step itself, it will automatically impairs the confidence of the clinician or confidence of the students, and indirectly it will affect the patient's treatment outcome. So before going into the access, the basic knowledge about root canal system and its components is very important. So you all know your enamel dentin and your pulp. In that you have your pulp horns. This is your pulp chamber and your root canal. This complete system is called as your root canal system. These are the root canal orifices, furcation canals, accessory canals, and apical foramen, apical delta. All these depicts the root canal system is the most complex system when you analyze in detail. Whatever in endo or whatever the understanding of your endodontics, it was very minimal part of the understanding of your root canal anatomy. There is way more complex when you go into your 3D structures of your root canal. So coming to the definition, access cavity is defined as, sorry, something happened. My screen is visible. Sorry for that. Excuse me. Is my screen visible? My PPT?
Yes, ma'am, it's visible, just not the slideshow view. It's in the normal view.
Oh, okay, sorry. Now
Yeah,
yeah.
it's fine now. Yeah.
Yeah, sorry for that. Access cavity preparation is defined as endodontic coronal preparation, which enables unobstructed access to the canal orifice, a straight line access to the apical foramen, and complete control on instrumentation and accommodate the obturation technique. When you see the definition itself, the access itself will determine how you're going to do your instrumentation and your obturation technique. So the main objectives of your access cavity preparation is to obtain straight line access. This was the one term you have to remember, the straight line access, which is very important for the success of your access preparation. And then conservation of your tooth structure and unroofing the pulp chamber and removal of your pulp horns. Straight line access. The straight line access is nothing but patent of your apical foramen into the canal orifices in a straight line without any crisscrossing of your instruments. This may be because of helpful in improved instrument control, improved obturation, and decreases the chances of procedural errors. So if you see this, this is a third molar, which was very tricky to do the endodontic access. So here, this straight line indicates in the mandibular third molar, the direction of orientation of your burr need to be gone to get the access to locate the orifices of your mesial canal. If with extreme curvature was there, so but to determine your straight line access, when you keep your endodontic files into all the canals, the files need to be straight without any crisscrossing. These are all the terms which I am talking regarding your traditional endodontic access cavity preparation. If you see this axis in the working length, the files are going straight, indicating a straight line access. In this, there was a curvature of your file, indicating there was no straight line access, and shown that this part of the root canal wall, will be remained untouched with the instruments. As the file was going in this direction, this wall will not be not instrumented properly. So little bit pushing of your axial wall or one of the wall to the side will lead to the straight line access in that direction. So next second objective is conservation of your tooth structure. To get a straight line access, you should not compromise your solid dentin. So conservation is very important because the wider access cavities will automatically weaken the tooth structure. If excessive removal of your enamel and dentin compromises your bonding and automatically weakens the tooth, this will increases the fractures and perforations. Next, third objective is unroofing the pulp chambers. So complete removal and deroofing of the pulp chamber is very important after location of your orifices, mainly because there may be some amount of debris or some amount of necrotic tissue present underneath the pulp chamber, which need to be disinfected and removed. So for that, the deroofing will mainly helps in maximizing the visibility, location of the canal orifices properly, and permits a straight line access and prevent discoloration of existing caries or restoration. So if you see the picture here, the unroofing was not done properly. So this was not allowing to negotiate this distobuccal canal of your upper molar. So here the pulp chamber, the whitish part which was left over, that was the roof of the pulp chamber that need to be removed, which you can be appreciating in the radiograph also. So after removal, if you see the access was completely clean, canal orifices were evident and BM and obturation was done. Before going into the loss of access cavity preparation, as said earlier, ma'am said diagnosis is very important and visualization of the internal anatomy is another thing which we emphasize. It's equally important after when you decide you are going to do for your root canal treatment. Yeah, am I correct? So before going into the internal anatomy, you have to observe few things in your radiograph and your clinical aspect. In the clinical aspect, you have to observe whether the teeth was rotated or any crowding, how the occlusal path, whether it was fully erupted or not. These are all the scenarios you have to keep in mind when you're going for your endodontic treatment. So when the x-rays, you have to see the occlusal anatomy, extent of your caries, location of your pulp chamber. This is very important while you're going to do your access cavity preparation, and see the approximate length of the root and the length of the canal. check for the patency of the canal to see any calcifications are present, any periapical lesions were present, and see the furcation area. When you start your axis, when you start here, your pulp chamber roof should be the terminus. When you accidentally encroached and go deeper, deeper, and deeper, you're going to land up in the furcation area, mainly in case of your molars. In case of single rooted teeth, most common thing you have to see was the orientation of your crown. If the crown was little bit 30 degrees tilt in case of your lower premolars, you have to change the direction of your handpiece and then keep the direction parallel to the long axis and perpendicular to the occlusion table. Same as your cavity preparation. Here also you have to keep in the occlusal orientation in mind. So extent of thickness of your root thickness, curvatures, all these have to be keep in mind when you're going to do your endo. So Krasner and Ranko proposed 9 different guidelines and laws for the access cavity. They studied around 500 teeth and determined that the cemento-enamel junction, it is the most important landmark for determining the location of your pulp chambers and the root canal orifices. This will determine where you can locate your root canal orifices easily. These all you're already well versed, I think, but brief intro into that for the laws. The first law is law of centrality. It states that the floor of pulp chamber is always located in the center. It is a three-dimensional structure. It is in the center, surrounded by your dentine and over your enamel. So it's always located in the center. So when the depth of penetration was there, you have to aim to reach the roof of the pulp chamber. Next one was your law of concentricity. It states that the pulp chamber is always concentric and parallel and located at the CEJ level. These was different access cavity pictures done by us demonstrating law of centrality and concentricity. So the third law was law of CEJ. This was the very important states that the distance between the external surface of the tooth and the wall of the pulp chamber. This distance is always same throughout entire circumference of the tooth at the level of CEJ. So here only you'll have that equidistance maintaining. So this CEJ is more important and are considered as a repeatable landmark in locating root canal orifices. First law of symmetry. First, in this, for all the teeth except for your maxillary molars, the canal orifices are always equidistant from the line drawn in the mesiodistal direction. So imagine this was your upper premolar. So always it will be, the axis will be in buccolingual direction. So buccal orifice will be under the buccal cusp underneath and the lingual orifice underneath of the lingual cusp. These are always equidistant from the line drawn in the mesiodistal direction. So it will be easy for us to locate the canal if we know where exactly that was present. The second law of symmetry. This also states that except for your maxillary molars, the canal orifices are always located perpendicular. In this perpendicular line only you have to negotiate. In the maxillary premolar, you can't find a canal here, here, and somewhere in the periphery. Always in this line, perpendicular line that was present perpendicular to the mesiodistal direction of your tooth. This was this loss of symmetry. And next one was your law of chiral change. Always when you see your access cavity, the pulpal floor will be always darker when compared to your walls. So these will be lighter, this will be darker. So next one was your law of orifice locations. The orifice locations is mainly 3 laws, first, second, and third. First law is always states that they are all located at the junction of walls and floors. So these the corners. Second law states that always located in the angles of your floor and wall junction at this point. So and third law states that it located at the terminus of the root development fusion lines. So at the end of these fusion lines, you can negotiate these orifices. So next comes your guidelines. What are the guidelines for your access cavity preparation? There exist guidelines for your anterior and posterior teeth. So first thing was preparation of your access through lingual and occlusal surfaces. For the anterior teeth, always you aim to do your access cavity on the lingual surfaces. Entry is from the lingual or palatal surfaces into the canal so that it will get to attain a straight line access. But for the occlusal surfaces, in case of your posterior teeth, you tend to keep your burr perpendicular to the occlusal table and the initial point of entry will be done, so that in some scenarios where mainly the teeth were treated, the canal was opened. In case of your incisors, lower incisors was the most common thing in this scenario. You can do your incisal access instead of, already this was treated, this canal was opened. So instead of again cutting all these amount of sound dentin structure, you can go for incisal access in those scenarios. So next thing was, once you do your occlusal or lingual access, you have to remove the culprit. The culprit may be either your defective restorations or your caries. So the entire caries has to be removed and entire defective restorations has to be removed before entry into your pulp chamber. So this why we are emphasizing was, sometimes we tend to leave these caries which was present on the proximal surfaces or this gingival below subgingival areas, which may affect the post-endodontic seal. That in turn leads to secondary infection or sensitivities, whatever post-treatment sensitivities. The complete removal of caries was not done properly, then the seal will be compromised. That leads to post-operative complications and symptoms. So sometimes in the first appointment itself, if we tend to remove entire restoration or entire defective caries, in those scenarios, the tooth structure will be very much weakened. So rubber dam placement also sometimes compromised in those areas. So some people may do whatever needed, that will be removed in the first entry and the rubber dam isolation will be done. Obturation will be done in the second visit. They tend to remove all the caries and tend to rebuild up that. But generally in the first visit itself, try to remove all the etiological factors present. So next one was your removal of your unsupported tooth structure. Always remove the unsupported enamel and dentin from the tooth in the access cavity. Refine your access cavity. If not, those tend to pose a cause for fractures in the future. If you do your unsupported enamel was left over and do an excellent post-endodontic restoration, when the patient tend to bite, it tend to break at that junction of the tooth and leading to the gap between your post-endo restoration and to the access. Next comes creation of an access cavity wall that do not restrict your straight line passage of the instrument to the apical foramen or the initial canal curvature. So here, if you see, the pulp horns was remained intact. This may hamper the straight line access into your distal canal. So this entire wall need to be removed to attain your straight line access. This was a concept in traditional access cavity preparation where you have to do complete deroofing of your canals. So last one was your location of your canal orifices and flaring of the canals and exploration of your root canal orifices. So these are all the guidelines what need to be followed for your access cavity. And coming to the principles of your access cavity, there exist principles like your cavity preparation, same as your access cavity in the coronal preparation and your radicular preparation. The first one will be your outline form, convenience form, removal of carious dentin or defective restorations, and toilet of the cavity. In the endodontic radicular preparation, you have your resistance and retention forms. So outline form. Here comes the topic where the internal anatomy plays a major role, because the internal anatomy, that is the shape of the pulp chamber itself, decides what was the outline form for the access of your particular tooth. If it is a maxillary central incisor, the triangular shape, which is the shape of your pulp chamber, the same will be depicted here. So it will be determined by size of the pulp chamber, shape of the pulp chamber, number, position, curvature of the root canals. Next one was your convenience form. This was your obstructed access, if you see here. So automatically, once the initial point of entry was done, the internal cavity preparation was done using a round burr, and then the convenience form was attained using your fissure burr or diamond point. And then the straight line axis was unobstructed access to the canal orifices, then patency towards your apical foramina, and complete control of your instrumentation. These all the factors need to be achieved in convenience form by extending your lateral walls. This was your mouse hole effect, many of you have heard, which we discussed later, where by extending this wall, the complete orifice will be present in the floor itself. Shamrock preparation. This was nothing but proposed by Lupke in 1983, where he stated that the entire wall here, if it is an extra canal is present or extreme curvature of the root was present, this entire wall need not to be extended for facilitate straight line access. Instead, only that portion of the wall can be extended. So when this only that partial portion of the wall was extended, so it resembles a cloverleaf appearance, and this modified access preparation is called as your shamrock preparation. Next comes mouse hole effect, which we said in the convenience form itself, you have to make sure this mouse hole effect is not seen, where it indicates that if there is no extension of your walls properly into the desired position, there sometimes the orifice may be located partly on the floor and partly on the wall. If the scenario is like this, the easy instrumentation and passage of instrumentation will be hampered, lead to unnecessary effects on the instrument. So extension of this axial wall is indicated so that the complete orifice is present on the floor itself. Next principle was removal of carious dentin. This we already discussed. Mainly this was done to eliminate bacteria mechanically, eliminate the discolored tooth structure, and eliminate the bacterial laden saliva. See, the class 2 caries involving here, the entire caries was left over. If this was not removed properly, the seal of your post-endodontic restoration will be hampered. That may be caused for future sensitivity or pain after root canal treatment. Even if your root canal treatment is excellently done with your three-dimensional obturation, if this post-endodontic seal is a failure, then patient will have some amount of symptoms. So here the complete removal is done. The same here, the margin need to be exposed and the caries need to be removed. So then the toilet of the cavity is nothing but cleaning of your cavity. All the caries, debris, necrotic material need to be removed, and round burrs and endodontic excavators can be useful. Always irrigate your pulp chamber with more amount of sodium hypochlorite. When we say sodium hypochlorite, it's inevitable that you have to do that procedure under the rubber dam isolation only. So irrigate with that and rub it off with your cotton, flush with your saline, and air dry so that the complete cavity was dry. So air dry, make sure if you use your chip blowers or three-way syringes, you should not direct it directly towards your canal orifices. Sometimes air may trapped inside and leading to emphysema. See, this was complete removal of any moisturizer present here. So this was one of the interesting phenomena. This was proposed way long back by Ranko and Krasner, mainly to understand the concept of your access to the students. He proposed one intact access box. This intact access box represents your intact tooth or your occlusal table of your tooth. What he made was different layers in that. First, this is your first layer, that is your first lid was removed. That is the initial point of your entry into the access. Only this part will be visible. When the second lid was removed, roof was removed. And then the third part was removed. Almost all the roof was removed, but still the canal orifices are not nowhere seen. So when the final lid was completely removed, then you can see all the canal orifices on the pulp chamber. So when they showed this to their students, they said that aha, so they named it as aha phenomenon. So next comes, what are the armamentarium present or useful in endodontic access? You all know your eroters or handpieces and burrs. Along with that, hand instruments also plays a crucial role in this. So what are the different types of burrs we are going to use? Round carbide bias of 2, 4, 6. Round end cutting tapered fissure diamond burrs. Safety tip tapered burrs. And transmetal burrs, Muller burrs and Munsey burrs. So initial entry of preparation need to be done with your tungsten carbide burr. Round and tapered diamond point will be later on used. And transmetal burr is used only when you're going to do your access with the crowns, metal crowns, or your heavy amalgam restorations are present. Unroofing the pulp chamber, the endo access burr with safe tip or endo Z burr was used. Even ultrasonics can be used. This was a transmetal burr which we are talking. It's a tungsten carbide burr where you can use your preparation when you're going through your amalgam or metal crowns or porcelain crowns. Next one was your pathfinders. Once you do your access to locate the canal orifices, you need explorers, DG16, CK17, micro openers, and ultrasonic tips. So these was your DG16 and JW17. Endodontic spoon, this is a hand instrument more resembling to your spoon excavator where you can remove your necrotic debris and pulp remnants. This was your endodontic explorer. Muller burr and Munsey burrs. These are nothing but these are modified burrs where if you see a receded pulp chamber where normal round burrs is not reaching towards your pulp chamber. Mainly if there are any calcified orifices, these burrs will aim to locate your canal orifice. Next one was your orifice enlargers. You have to keep this in mind. In this concept was mainly in case of your traditional access cavity only. In these designs, they propose the concept of precoronal flaring. For precoronal flaring, they tend to use gauge glidens or orifice openers. Gauge glidden drills, you all have seen this, mainly to flare the canals. Precoronal, only coronal third, only you tend to enlarge with that. Smaller size to bigger sizes are available and facilitate easy instrumentation. Then the orifice openers was proposed for precoronal flaring. But later on, with the advances present here, the modern endodontics was emerged. The two terms which was very important to keep in mind was your pericervical dentin. So when you do this orifice openers or use your gauge glidden drills, this pericervical dentin is one thing which was severely compromised to facilitate this instrumentation. So now this concept was little bit reduced, that precoronal flaring. So before going in detail, what was the steps for your access cavity in anterior teeth? So there exist different steps for your access for anterior and your posterior teeth. As said earlier by the ma'am, Nisha ma'am, diagnosis is one thing where it's very important for endodontic treatment. So no patient will want to expose to unnecessary root canal treatments. So have a detailed diagnosis, have a concrete treatment plan, then only decide for your endodontic treatment. After that, other thing I want to emphasize was your pre-operative steps. First thing was your knowledge of your internal anatomy. You have to know in detail internal anatomy of all the teeth, that is from starting from your maxillary centrals to your mandibular molars. All the teeth you have to know how many canals was present, how much will be the root length, what will be the chances of extra canals or extra roots, if there any anomalies present in that tooth. So clinical examination followed by radiographic interpretation is one thing, is prerequisite for your endodontic treatment. After that, rubber dam isolation. So always you have to do your endo treatment under rubber dam isolation. If the rubber dam isolation was not done, the success of your endodontic treatment will be compromised. When a long-term survival rate was checked under rubber dam isolation endodontic treatment and without rubber dam isolation, within 3-4 years itself, if the success was around 90 to 95% under rubber dam, it will be compromising up to 80 to 85% without rubber dam within a span of 3 to 4 years itself. So they tend to go for leakage, secondary infection, pain may not be resolved, patient may have sensitivity. So all these have to be curbed. If you only have a proper protocol and isolation factors present. So next thing was your outline form and initial entry. The outline form, as said earlier, will be determined by the internal anatomy, that is the shape of your pulp chamber. So the initial entry always for the maxillary anterior teeth or mandibular anterior teeth will be palatal and your lingual surface. You have to keep your burr perpendicular to the lingual surface and initial point of entry to be done into the enamel dentin right up to the pulp chamber. Then change the direction of the angulation of the burr to the parallel or 45 degrees and then gently penetrate into the pulp chamber. When you proceed inside to the pulp chamber, you may feel drop-like effect. That drop-like effect indicates that you have entered from the pulp chamber, the roof of the pulp chamber was removed and you entered into the pulp chamber. So then only you can go for unroofing of your pulp chamber. So removal of your lingual shoulder is later and then flaring of the canals is indicated. Now comes it out, what if the drop was not felt? So if the drop was not felt, there may be different scenarios, like your calcifications may be present, there may be change of angulation of your burr. All these have to be assessed. And then if your orientation was not going properly, you're going more deeper and going more buccally, which may lead to your perforation. So you change the angulation and locate. Always your why we are approaching towards the lingual axis is in the anterior teeth, you'll get an easy entry into the pulp chamber from the lingual surface. So if you feel you're not going, it means you're going too much buccal. So come back and again change the angulation and search your canal in the lingual surface only. So if drop was not felt, take your DG16 Explorer, try to explore the orifice. When you feel the orifice, then you can extend your axis in that direction. The same with your axis for your posterior teeth. Preoperative assessment, isolation, visualization of your internal anatomy, but here the initial entry will be from the occlusal surface. If it is a premolar, it was from the occlusal surface, and even from the molars, it should be perpendicular to the occlusal table. Always, you should not compromise your oblique ridge when you're going to take your entry into the. So mesial occlusal table is the aim for the axis for your maxillary molars. So all the orifices you can gain straight line from the mesial marginal ridge in between oblique ridge itself. So the triangular shape will be formed and you have to penetrate into the chamber. The same like the drop-in effect will be felt. If it is not felt, also take your explorers and explore. First, always aim for larger canal. If you're going for your upper premolars, try to locate your palatal canal and then go towards your buccal canal. If it's same with your mandibular molars and maxillary molars also, always go for your palatal canal first, then try to visualize the anatomy and then try to locate. Always the mesiobuccal orifice will be under the mesiobuccal cusp. In case of your maxillary molars, distobuccal cusp is the one tricky thing you have to evaluate because it will be present under the oblique ridge sometimes in between your mesiobuccal cusp and your palatal cusp. So different positions it may. So always first locate your palatal and then go for mesiobuccal, then locate your DB. This was the scenario in case of your maxillary molars. And mandibular molars, you always start with your axis, locate your distal canal, and then extend towards your mesiobuccal and your mesiolingual. Keep in mind, mostly the mesiobuccal canal will be shorter and mesiolingual canal will be longer. So the two canals will inevitably present in case of your mandibular molars. Sometimes the distal canal, which is maybe ovoid single, or sometimes it may be presenter two separate canals. So three canals in mandibular molars or four canals in mandibular molars may exist. So then after location of all the orifices, refine the walls, complete deroofing of the pulp chamber need to be done, and then straight line access need to be achieved. Am I clear up to now? Any questions? Okay, I'm continuing. This was the different access designs for your upper and lower teeth. As said earlier, the shape of the pulp chamber decides the shape of the axis. So triangular shape for all the maxillary anteriors and mandibular incisors. Whereas the maxillary canines in the maxillary anteriors, it is oval shape. In case of your upper premolars, two orifices will be present and it is ovoid in shape. The same with your upper second premolar also. Here, two orifices will be present. Sometimes it may be exit the root canal in two different orifices or may be fused inside. So 2-1 configuration most commonly seen here. Mandibular molars, triangular, rounded triangular. And then comes your mandibular canals, oval, premolars, ovoid. Here, either rectangular or trapezoidal in case of your mandibular molars. Here is a short video of your axis cavity shapes of different teeth. So this is 3 canals, 4 canals mandibular molar. Extra canals. This was the standard shapes. So always know the landmarks before going to your axis preparation. So other concept which comes was your pre-endodontic buildup. Pre-endodontic buildup is nothing but building the lost tooth walls around the axis using your composite. So what happens if your tooth structure was entirely lost? The proximal caries was involving from the distal side towards the pulp chamber. In those scenarios, you have to remove entire caries and do a pre-endodontic buildup so that it can provide a solid structure for your rubber dam placement. Mainly indicated when insufficient tooth structure was present, help in proper rubber dam placement, also improves retention of your interim restorations. So next comes the scenario where it's indicated. Grossly decayed teeth, fractured crowns, and poor retention for temporary. So the buildup need to be done. Then only you can keep your rubber dam properly. Advantages, dry operating field. It will increase the resistance from the fracture and temporization. Temporary restorative material will withstand in the axis. Procedure, remove the caries and soft tissues if any present. Go for cautery or laser and achieve the hemostasis and place the gingival retraction cord. Margin exposure, deep margin elevation need to be done and place a cotton pellet and then give a flowable or packable composite. Why we place a cotton pellet in the access area is so that this restorative material will not flow into the orifices and block the canal orifices. So what was a major breakthrough that happened in the endodontics which changed the entire concept of endodontic access preparations? That is this. How many of you have seen endodontic microscopes and magnifying loops? Anyone? You can unmute and answer.
Yes, ma'am.
Yeah.
Yes, ma'am.
Okay. If you have any chance of using, at least try your preclinical in that area, just to visualize your anatomy under that, so that you can see how magnifying image you can get in that under your microscope. So these two are breakthroughs in the endodontics where you lead to the concepts of minimally invasive endodontics. Now, whatever the concept I said up to now was your traditional endodontic access. So what is minimally invasive endodontics? It's nothing but preserving the healthy structure. When you try to attain your straight line access, you tend to compromise all the healthy tooth structure present in that area. So this concept tried to preserve maximum amount of coronal, cervical or radicular tooth structure. This can be implemented in your access, cleaning and shaping procedures. So now the concept was this endodontic access was divided into two concepts, that is traditional concepts and minimal invasive concepts. So in the posterior teeth, up to now, what I said was the principles of your traditional. As said earlier, anterior lingual access, facial access, or incisal access you can do. But in minimal invasive, you have your conservative, ultra conservative, and computer assisted access cavity preparations. In conservative, you have your contracted access cavity in molars, the same with little bit conservation of tooth structure. In ultra conservative, you have your truss access, ninja access. Computer, you have your static guided endodontics and dynamic guided endodontics. In this, you have your guided endodontics and dynamic navigation in that. Mainly, these will be helpful in case of your trauma cases or calcified canals. In those where your normal access will not able to negotiate your root canal completely. In complete calcification, this guided endodontics will guide us to the same root canal pathway. Instead, if you try your traditional methods in this, you tend to go either buccally or lingually or mesially and tend to perf the canal, or either lateral perforations, root perforations may happen. So this guided template will guide you into the root canal straight through the calcifications. So before going into these modern concepts, you have to know about two things: pericervical dentin and the soffit. This PCD is nothing but the dentin present 4 mm above and 6 mm below in this area. So always the tooth strength after the root canal will be determined by the amount of how much amount of your pericervical dentin is present. More you save this area, the more strength of your tooth will be present. So this was called as a critical zone. Transfer of your occlusal load from the crown to the root will be happen through this area only. This will further prevent fracture of your tooth. So by a systematic review and meta-analysis, they stated that PCD is very important in preservation of the tooth structure in cervical area, mainly enhancing the fracture resistance of your tooth. Even in case of your incisors, that cingulum or pericingulum dentin, what all the steps in traditional I said, you have to remove your cingulum and you have to remove your pulp horns and roof of the pulp chamber, all need to be removed in the traditional access. Now they are saying they have to preserve that so that the fracture resistance will be there for the endodontically treated teeth. Next thing concept was your soffit. They stated that this was your traditional access you done. For removal of these pulp horns, you have to extend the access little bit as a diverging walls up to here. But now the concept was you no need to remove this pulpal horns, the straight access to the canals, and provided if you have an excellent disinfection protocol. If the disinfection is not proper, this again acts in nidus of microorganisms and leads to secondary infections. If you mechanically was not done, then your cleaning action need to be more perfect in this area. So now comes the recent concepts, that is conservative access and conservative access with diverging walls. So here you do a conservative access and then involved to your pulp chamber and entire roof was removed and access was attained. But this pulp horn area, whatever present, if you have to remove this, you have to extend up to here. So unnecessary cutting of your sound enamel dentin will happen. So for that, you have to preserve this pulp horns. That was the concept of your conservative access. So this was where you will have little bit diverging walls to facilitate more irrigation and more instrumentation. Next one was your ultra conservative access cavity, where even smaller cavities will be prepared. From this smaller cavity itself, all the canal orifices will be negotiated, in which this extreme unroofing of the pulp chamber will be there, but preservation of your pulp horns and this soffit area and PCD, everything was preserved in this and providing a converging walls. Now comes the concept how the instrumentation will be. So in these cases, extremely flexible instruments need to be used in case of your night eye instruments, and straight line access will not be attained in these areas. Next comes the concept of truss access. This truss access will be possible only in case of your molar teeth, where you have two different roots, mesial root and your distal root. What they proposed of, they do is separate access cavities from one's on the mesial side, other on the distal side, and entry into the canals and patency was attached. So here also beneath this enamel and dentin and roof of the pulp chamber, there exists necrotic debris in between. See here, this area. So for this area, that need to be flushed with your sodium hypochlorite and irrigation activation need to be done so that this was completely cleaned. So in cleaning and shaping, this area is not shaped. This area was cleansed properly and irrigation activation was performed so that the secondary infection won't happen. So here in this mesial axis, you locate two canals, and in distal small axis, you locate your distal canal. This is your truss axis. That was nothing but orifice directed axis with separate cavities. So next one was your caries driven axis. Whatever in traditional I said, caries need to be removed and that entire thing need to be restored. That is your pre-endodontic buildup need to be done in those areas, and again traditional axis need to be done. So in that one side, entire restorative margin will be there. Other side from the occlusal surface, you'll have your post-endodontic restoration. So entire solid tooth structure was compromised in those areas. So this caries driven axis is nothing but where the caries was present, from that area itself, you will going to take the entry into the pulp chamber. If the caries is present in the proximal surface, from the proximal surface, you extend little bit occlusally and then get the entry into the pulp chamber. So this was your cervical abrasions involving your pulp. Here, what they tried to get was remove this, get the access through the area. So mainly in case of your mesial caries, most common scenario that is caries acquired access cavity will be seen in distal side of your upper teeth. Mostly the distal caries will be most common in case of your upper molars. So in those areas from the distal side itself, when you tend to remove all the caries, you directly land up in your either palatal or distal orifice. From there itself, you tend to extend towards your mesial surface. So this was your caries driven axis. See here, the caries was present on the mesial surface. From here itself, they directed and did the obturation and seal. The entire occlusal surface here up to this area was preserved. So next one was your restoration driven access cavity. In the restored teeth, when there is no caries was present, but IRCT was indicated for other reasons like your apical periodontitis, etc. In those, partial removal of restoration was done and access was performed. So next one was your ninja axis. Truss axis and ninja axis were your ultra conservative mode of your axis, where very small hole was prepared on the occlusal surface, and from that itself, you tend to get access to your root canals. So in a study published in Journal of Endodontics, they stated that traditional axes have showed lower fracture strength when compared to conservative and ninja. Obviously, in traditional axis, you tend to remove more amount of tooth structure, so automatically tooth will get weakened. So the fracture resistance will be less in case of the traditional endodontic axis. They are proving that unnecessary removal of your tooth was not needed just because to get your straight line access, because now there was advances in case of your irrigation activation and protocols. So straight line access at the compromise of tooth structure need not to be done. These are the recent concepts. Next one was your calla lily enamel preparation. It resembles like this flower, calla lily flower, where I stressed on removal of unsupported dentin, right? Enamel and dentin. So in this, mainly the 45 degrees bevel will be given in the enamel and dentin of the endodontic axis area, so that when you give your post-endodontic restoration, more amount of bonding will be seen and fracture of your unsupported enamel rods will not be seen. So next comes your guided endodontics, that is your static and your dynamic. In the static, you'll have your CBCT and your intraoral scan will be done, and a 3D printed template will be fabricated. From the 3D printed template, you tend to have a virtual drill path that will be incorporated into the template. If the same template will be used in case in the patient, the same path will virtual drill path will be replicated. You will not to tend to go the deviation of the path so that the perforations will be avoided. As I said earlier, these guided preparations was indicated only when there is complete calcification of the canals or entire coronal middle third was completely calcified due to trauma, long-standing infection or long-standing trauma, and apical third patency was present and periapical lesion present, where you have to negotiate the canal completely is mandate so that the periapical infection also has to be resolved. So in those cases, you prefer this. So here, the template was prepared on the CBCT scan and then replicated in the 3D modeling. The same template was fit checked into the patient's mouth. Here, when you want to negotiate these central incisors, lower central incisors, this template will guide so that at this center region only you tend to penetrate with your burr so that there won't be deviations towards your mesial or distal or buccal or lingual so that you can negotiate your canal without any iatrogenic errors. This was a small video if you're interested to see how the process is going on. This is a trauma tape. TOP was present. See, the canal was completely calcified. Apical third was patent. CBCT analysis was done. Then the virtual drill was performed. Pathway insertion was determined. The same was replicated. 3D guide template. Same was attached to the teeth. Access was performed. So next, that was the static access. Now comes your dynamic navigation. There was very shortcomings in case of your static guidance. Sometimes the replication was not that much perfect. So few shortcomings was there in static guidance. Only one path was inserted. So they introduce a concept of dynamic navigation where you'll have your virtual drill paths. CBCT monitoring will be then the same thing will be superimposed with the help of a jaw tracker placement on the patient, and the track will be established. This dynamic navigation is an XNAV system. There exists a three-dimensional camera. When you tend to do the access here in the patient mouth, that will be displayed onto the monitor whether you're going in the right direction or you're deviating the pathway of the axis. So this video where you can see the fabrication of the dynamic navigation stent in case of your upper central incisor. So the path was decided and locked. CBCT of the model was being done. So now the path was being replicated on the 3D guide with the help of CBCT scan and 3D reconstruction. So then this jaw tracker was placed onto the patient's mouth so that this jaw tracker will help to transfer the data whether we are going straight into the canals or onto the virtual guide. The patient registration was being done. This was the jaw tracker. The patient registration. Fit check was being done. Rubber dam isolation. The same. The drill calibration was being performed with the help of this guide. If you're going in the straight pathway, it was fine. You have to hit your bullseye in that point. If you're deviating from this bullseye, that indicates that you're deviating the pathway. So again, you have to change the orientation of the burr and direction of the burr and negotiate entire calcified canal. Any doubts up to now? So up to now, I covered what is traditional access and what was the different advances and modern advances in case of your access cavity preparation itself. Next one, what the difficulties you tend to face when you do your access? First thing, yeah,
Ma'am,
yeah, ma.
in dynamic one, 3D printed models is not needed, like it's directly done.
Yeah, in static, you need 3D printing models, ma. In dynamic, you tend to transfer the thing. Jaw tracker placement will be done. The path will be decided. With the help of the guide, you tend to place. Printing no needed. Only CBCT analysis was needed.
Ma'am, can you tell the difference between the truss cavity and the ninja axis?
Yeah, ma. Truss cavity is nothing but orifice oriented access cavity, ma. Means if you're having mesial root and your distal root, in case of your mandibular molars, you tend to prepare two different cavities. In the truss cavity, on the mesial side, you tend to locate mesial buccal and your mesial lingual. In case of your distal, you tend to locate distal canal. So two different axes will be there. This trust axis and also your ninja axis is both are ultra conservative mode of access cavity preparations. And in case of your ninja axis, only a smaller hole will be placed in the central fossa, mainly in the lower molar. And from that smaller hole itself, you tend to negotiate your mesial and distal canals. Single or excess cavity will be there in ninja, whereas in truss, you'll have two different axes. Am I clear, ma?
Yes, ma'am.
Okay, any other doubts or shall I proceed? Hope it's not boring.
Ma'am, can you explain soffit once again and the
Yeah,
pericervical dentine also?
yeah, ma, sure, I'll do it. Soffit is in the initial itself, I said complete removal of your pulp chamber roof is needed. So whatever the lingual cingulum was present or your pulp horns was present, that need to be removed. So here if you see, this area need to be removed in case of your traditional access cavity preparation. But in case of this soffit, what the Clark and Kedeme says that this small piece of roof pulp chamber can be retained, this part and this part. Mainly to remove this area, you have to extend your cavity and cut all the sound dentin and your enamel top here. So you have to keep your diverging walls here and then cut sound dentin. So what they stated was, while preserving this soffit area, you can leave off this pulp horns and extend your cavity up to here only. So no need to extend towards your dotted lines. So this area is called as your soffit. Mainly the banking of your tooth structure, means preserving of your tooth structure. This will prevent unnecessary gauzing of your teeth. While removing here, you tend to keep your round burr inward and lock it, and outward pull will be given to remove that. So the unnecessary cutting will be there all these areas. To avoid that, they said to preserve your pulp chamber itself. But when you're doing this, you have to follow your irrigation activation properly. Okay, ma'am. Still any doubts? Can I continue? Okay. What are the difficulties you tend to face during access? First thing, when you go for enamel and dentin, you'll land up in the pulp, blood. Up to now, in your class 2s or class 1s, you don't go near to the pulp. So first thing here you see was how to control this blood in the pulp chamber floor. So excessive bleeding, if it was present, means it was your pulp tissue was still little bit not completely necrotized. So you have to remove entire fibrous tissue here. Either you can use your hand files along with your irrigation. Sodium hypochlorite plays a major role in this, and EDTA also. So you have to remove this entire excess bleeding and control the bleeding. Then only you can negotiate or locate your canal orifices. So next one was your inadequate removal of your pulp chamber. As said earlier, in traditional, you have to remove the pulp chamber roof and unable to locate all the orifices. So sometimes some tricky canals will be present. Mainly in this case, this was your middle mesial canal. What up to now we heard was in the first molar, you have either two mesial canals and one distal canal or two distal canals. This was a common routine. But in some scenarios, you find third extra canal in the mesial cavity or mesial root that is called as your middle mesial canal. So you have to negotiate all the canals, whatever present in the anatomy of the tooth. So that's why we say the root canal anatomy is very complex. More you go inside, more you fascinated will be with the anatomy. However much you do your access or perfection in endo or perfection in your obturation or instrumentation or irrigation dynamics, only 60% of your root canal will be touched and cleansed. Remaining all will be untouched areas only. So that much how complex your root canal was. So next one was your calcifications or pulp stones. You all know what the pulp stones are. True pulp stones, false pulp stones, and your embedded, free. So these pulp stone will hamper the location of your orifice. It completely covers the root canal orifice. The pulp chamber where you see the calcifications, this has to be relieved and removed. If it is a free pulp stone, you have to, whatever the engaged part here, that need to be drilled, and then entire pulp stone should be scooped out with the help of your endodontic spoon. Sometimes that was attached to denticles will be there. Those have to be not completely removed. Only the orifices area need to be negotiated, drilled, and orifices need to be negotiated. So here, if you see, this was a free pulp stone present. With the help of your endodontic tree, after disengaging that from all the dentin walls, with the help of endodontic spoon, we tend to remove the pulp stone. So then only you can see your pulp chamber properly and locate the orifices properly. So what were the challenges you faced during access cavity preparation? One was your minimal crown or no crown, heavily restored teeth, teeth with calcified canals, crowded teeth, and rotated teeth. So these are the scenarios where completely already tooth preparation was done, secondary caries was there. So tooth structure was very much minimal. So entire was removed. Our plan is to do the endodontic preparation and give a post encore over that the crown. So if you see here, the tooth was completely compromised. As we are planning for your cast post in this case, we don't need to do your pre-endodontic buildup. So the rubber dam was not placed. So it was compromised in this area. Even sectional could not be possible because of your heavy spacings was present in the adjacent teeth of this case. So heavily restored teeth, where if you all know the restorations will somehow affect your pulpal tissue. if you do some amount of restorative material on a long standing, the pulpal reactions will be seen. So here you have to see whether the pulp chamber is receded or not. Sometimes the pulp chamber itself may not be visible completely. So measure against your radiograph, how much depth you can go, where was the furcation. So based on that, you have to go the entry, use the bar against the radiograph to estimate mainly the pulp chamber level and your furcation level. So in these cases, you have to be a little bit cautious. So here, this was, I can say it was a restoration driven access, entire MOD cavity was present. So for rubber dam facilitation, we remove part of the restoration and do the access cavity and done the obturation. In post-endo placement, we replaced entire post-endodontic restoration. Teeth with calcified canals. This was one of the toughest thing to deal in case of the endo. Negotiation of the calcified canals is mandatory in some scenarios. If the periapical lesion was present, patient is not complaining any symptoms. If you see any long-standing trauma and complete canal was calcified, not even apical canals was patent in those. So better not touch those teeth. If the patient complaint is pain or any periapical lesion was present, in those scenarios only you have to touch the teeth and have to negotiate the canal properly. So if you find any difficulty in negotiation and if you feel that you're going out of the path, then go for CBCT analysis and determine where the canal was patent in that. According to that, you have to plan your access cavity preparation. So radiograph may show partial or complete obliteration, but still some space will be there for microorganisms in that. So lesser calcifications will be seen at the apex only. In calcified canals, only apical third will be patent, remaining all will maximum calcified. Assume always the canal is present. If you want to negotiate, the scenario is that then you have to negotiate that teeth. So what was the methods to locate your canal orifices mainly? You can use your magnification or illumination, dyes, 1% methylene dyes, fiber optic lume, transillumination, champagne bubble test, mainly in case of your sodium hypochlorite was entire cavity was filled with your sodium hypochlorite and then bubbles will be erupting if there is any canal orifice. That is called as your effervescence. That is called your champagne bubble test, red line test and white line test. So next scenario was your crowded teeth. This was the scenario. You tend to do your treatment for all these teeth. So conventional preparations in these areas is not possible because when you're trying to do the access of one teeth, other teeth will be hampering your erotor placement. So in those areas, what we suggested was caries driven access, so that if this caries was completely removed, then you can get the patency of the canals. Either ninja access can also be done, very conservative access in those scenarios. So the canal was, and another difficulty in these cases was your working length determination also. The overlapping of the roots of these, all the two teeth will be a major obstacle to know the terminus of your root. So in these scenarios, electronic apex locators will be helpful. So rotated teeth, another one. So clinically, you have to visualize how the tooth was, whether it was in buccolingual direction or major distal direction. And then you have to visualize your anatomy. If premolar was rotated into the arch, so then you have to do your access in major distal direction rather than your buccolingual direction. So you have to pre-assess your clinical scenario and your radiographic scenario. What are the procedure errors commonly will be done was you're treating the wrong tooth. Whether it was indicated or not, sometimes you tend to do your wrong tooth RCTs in case of your intentional RCTs. If the proso people advise for intentional RCTs, by mistake, you tend to do 1-4 or 2-4 confused and get to do the wrong tooth. That was a big mistake. So be cautious. Ask the patient history so that you will get some amount of diagnosis. They will point out which tooth need to be done. If you're confused, even when the OP people in the OPD also get to confused and tend to write the wrong tooth. So when you are doing a tooth, ask the patient what the complaint, why he came, what the diagnosis, you tend to attain. So take your own case history instead of depending on the OPD case history. So next one you tend to encounter was your missed canals, damage to the adjacent teeth or existing restorations, perforations, and crown fractures. So next thing was your underextended cavity or overextended cavity. So this underextended cavity where the mesial orifices was not completely seen. Overextended cavity, more amount of tooth structure will be lost. So these are all the things up to now about your access. Next was your anatomy uncovered and rubber dammer. These two I'll cover in short. You all know what was the basic anatomy of your root canal system, what was the components of that, how many root canals was present, and what was the classification. In that, these are the classifications you tend to know. Vertices, veins, certain Bailey's, and Gulabiwala. Instead, at least you should know about your vertice classification. So as I said, in the upper premolars, they tend to have 2-1 configurations most commonly. So the orifices may be 2, but at the end it will be apex, the opening will be 1 only. So this was 1-1, 1 canal at the apex, these 3, 1-1, type 1, type 2, type 3, and 2 canals at the apex in these scenarios, and this one, 3 canals at the apex. This was your veins classification, 1-1, 2-1, 2-2, 1-2. So if the question was about your internal anatomy, so little bit about the classification of at least 1-2 classifications will be fetching. So certain Brailleys, this was extension. And then next one was your Gulabiwalas. So before going into these complexities, I want to showcase what was the micro-CT canal anatomies. Premolars has the maximum complexity of the root canal systems, upper and lower premolars. Central incisor, lateral incisors. Mandibular centrals and laterals usually have 2 canals or 1-to-1 configurations. So now I'm presenting different cases where in the lower incisors with 2 canals, here 3-1 and 4-1. Always in the X-ray, if you tend to see either this bifurcation, because this is a rotated teeth, you can appreciate this. But if it was not a rotated teeth, if it is a normal angulation, you see the canal here, in the middle third, it's suddenly radio opaque. And at the apex, you have a radiolucency. It indicates a bifurcation. Sudden disappearance of the canal in the root canal system always indicates a bifurcation. In those, you have to take angulated x-rays, then you can come to your anatomy. This was your 1 dividing into 2 in the middle third and exiting as a 1-1 configuration. Here the 2 canals was present. In our population, these canal configurations tend to change to population. In our population, the lower incisors, you tend to find 2 canals more obviously. So this is negotiated and obturated. So this was your maxillary lateral incisors, 2 canals, and then your 3 rooted lower premolar. This scenario is very much different. You tend to not find 3 rooted lower premolars. This was 1 to 2% prevalence. So radix entomolaris and paramolaris, these are the 2 scenarios where you can see extra root present. Here, all the canals were negotiated and obturated. MB2 canals. So why we are stressing extra canals was, these were also most reasons for the failure of your root canal. So MB2 earlier, they tend to say only 30 to 50%, but when you negotiate under your magnification and surgical microscope, 85% of the cases you tend to have MB2. So always when you're going to treat your upper molar, fix in mind that always MB2 is exists. So in 85 case scenarios, you'll find MB2 canals. So here, if you see, mesobuccal, MB1, MB2, palatal, and DB. These are the different scenarios where we found MB2 canals, all the axis, all the working lengths, middle mesial canals. Earlier, this percentage was only up to 3 to 12%, but now this percentage was also increased to around 20 to 25%. Obviously, in 12% cases, you tend to find middle mesial. So always search that there exists some canal, but don't tend to over search or perf that area. So this was also the another case of your middle mesial CBCT analysis. This was in another 3-rooted upper premolar. 3-rooted upper premolar chances was 2 to 3% only. In first molar scenario, you can see 3-rooted upper premolar resembling like a molar, but in second premolar area, it was very rare. So we was little bit tricky about this configuration. So we suggested CBCT analysis. In different views, they negotiated and give the gradings. And the furcation where the bifurcation of the root was seen was around here. You had to tend to go around 8 to 9 mm, and then the bifurcation was there. So under microscope, we successfully negotiated and obturated. So next cases was your dense invaginators. One slide from earlier presentation from Nisha ma'am, very striking, that is palatogingival groove extension slide. If you remember, that groove was extending from this cingulum area towards entire to the length of your root. So sometimes this palatogingival grooves are also a problematic and cause for reason for your periapical infection, that is your anomalies. So here the patient clinically nothing. If you examine, the tooth was fine. But when you take a radiograph, patient is having symptoms and periapical radiolucency was seen. So when you take an X-ray, you suspected your dense invaginators, and we advised the CBCT. 2 separate canals was there, so negotiated and obturated. C-shaped canals is one thing other you commonly seen in case of your mandibular molars. So different types of Olliet's classification was there, complete single C, 2 different, 2 or 3 canals, single lumen, whole lumen. So up to now, this was the tricky configurations of the endo we faced. So next was your rubber dam isolation. This is one of the very prerequisite step. Goals is mainly moisture control, retraction, and patient safety. So S.E. Barnum introduced this. You all know this. Advantages was to provide dry, clean operating field, improve accessibility, does not disturb the properties of your restorative material, increases the productivity of your restoration. Components, you know, a rubber dam sheet, clamps, wedget, frame, retainer, forceps, clamps again, wings and wingless. So basic, you all know these are the Coltine clamps. You find different color codings here. In some other companies, you tend to see numbers here for indication. This butterfly clamp is for your anteriors, premolars, molars, and serrated and non-serrated will be there. Serrated for improved retention. When the teeth was grossly decayed, so more retention was needed. In those case scenarios, you tend to go for your Brinker clamps. So rubber dam template, forceps, depending on the size, you tend to punch your holes. Okay. Now, what I'm stressing was your recent advances here. When you go with your standard frame, for every time when you're going to go for do your X-rays, you tend to remove the rubber dam sheet and then go for your RVG. So here with the articulated things, you can fold the rubber dam and then you can give your X-rays. Safety frame, NC dam, handy dam, framed flexi dams. So again in isolation, you'll have single tooth isolation and your multiple tooth isolation. In the methods, you have clamp first method, then dam first method, and simultaneous method. This simultaneous method is more easier to perform. So American Endodontics suggested that rubber dam is mandatory for all non-surgical endodontic treatments. It's compulsory. Performing root canal without rubber dam will be legally suitable. So there exists some laws. So when you have to follow your professional standard of care, you have to do your RCT under rubber dam. So barriers why practitioners are many not using rubber dam. The reasons may be time constraints, cost factor, patient compliance, and lack of enough training. So this was the different scenarios you tend to face, like where heavily restored teeth will be there, tight contacts will be there, and rotated teeth will be there. Adequate structure was not present. So different scenarios will be there where rubber dam placement may be not possible. In those cases, you can go for adjacent teeth isolation and give a sectional isolation and good floss type. So this I conclude, every successful root canal treatment begins with your knowledge and practice perfected to the precision. So you need continuous training. So excellence in endodontics is not achieved by not only mastering the instrument, but also combining that with your scientific evidence and clinical precisions and practice. Thank you. These are my references. Thank you. This I conclude. Thank you for
It
giving
was
me
a very
this
wonderful
opportunity.
and brief lecture.
Thank you so much, sir. I think I'm over the board of time.
No, ma'am, it was already 15 minutes delayed. There's not an issue. Any of
Okay.
the participants, if you have any doubts or questions, you can ask. We have 5 minutes for the Q&A.
So where is the chat box?
There is a question.
Pericervical dentin.
Yeah.
A pericervical dentin is the dentin that is present 4 mm above the crestal bone and 4 mm below the crestal bone. So this dentin acts a major role in endodontically treated teeth to transfer the load from your crown to the tooth. So while doing your traditional access cavity preparation, you tend to encroach this pericervical dentin area. So the modern concepts say that these plays a major role in fracture resistance of the tooth. So this need to be preserved. Am I clear?
Yes, ma'am.
Thank you. Hope everyone got a good session on this.
Yes, ma'am. It was a wonderful session. Thank you so much, ma'am.
Thank you. Thank you so much.
We're gonna proceed to our third session of the day.
Yeah, I'll sign off.
We have Dr. Yash Sharma with us. He's Associate Professor in Department of Conservative Dentistry and Endodontics at Pacific Dental College and Hospital, Udaipur. Sir is gonna talk to us about biomechanics, disinfection, and irrigation, about the shaping smarter, not harder, rotary, reciprocating, and hybrid system made simple, irrigation beyond sodium hypochlorite, activation, new solution, and avoiding toxicity, infection control in endo, microbiology, biofilm, and cross contamination protocols. We welcome you, sir.
Thank you so much. Just give me time. I will just attach my PPT.
Sure, sir.
Is it visible or not now?
It's visible. It's visible.
It's visible.
It's
Thank you.
perfectly fine.
Okay. Thank you so much, Shubham. Myself, Dr. Yash Sharma. I'm working as an associate professor in Pacific Dental College, Udaipur. Today, I'm going to take my topic on related to biomechanical preparation and irrigation and like my various technique we use in our daily practice to do the BMP procedure or irrigating procedure, and like what all endodontic failure or mishaps we face during doing these kind of procedures. So as of now, ma'am had covered all these topics. You would have seen these kind of access opening, everything like how you're going to use your instrument or armamentarium. जैसा कि आपको देखा होगा आप लोगों ने कि like these kind of armamentariums are easily available in markets, but like we don't know like which armamentarium we have to use. Sometimes we try to use our directly straight burr rather using number 2, number 4 round burr, just to ease to remove the time deficiency or anything. Like for shortcut we think like it's okay, we use the straight burr and we end up doing all perforation. So in short duration till now you would have seen all these things, and like this is the main criteria whenever I start doing BMP procedure: scouting and glide path. So if anyone asks like what do you mean by scouting and what do you mean by glide path, like everyone got to know how to do access opening, how what all procedure you have to do and what all precautionary measure you have to take while doing access opening, and like how much depth you have to go inside till remove the interradicular area, pulpal floor and everything. But after that only the main part starts. Like you should know like how many number of the canals are present and how you are going to proceed till the apex. So all the there you have to like get to know all these things. Like by in my session I am going to cover all these things in my session. So what do you mean by scouting? Scouting is the procedure in which that you are going to find the how many number of canals are present with the help of your K files. Like you got know all these things happens like just wait a minute. Okay. Scouting is the procedure in where like you get to know that number of canals are present or not, how many number of canals are present. So you start doing with the help of the number K file. Like generally nowadays, what young dentists they are doing just to do like the procedure in faster way. Just they just take the rotary instruments and they start doing the BMP. No, first go with the basic procedures. First, as per basic rule, you have to check the how many number of the canals are present. So with the help of K files or smaller number K files, either 6 or 8, you can check for the number of canals. And the moment you find the canals, after that you have to go for the path, whether it's straight path access or whether it's a pre-curved canal or whether it's a bifurcated canal. So all these things you have to find in your procedure. So scouting is like first, whenever you're doing access opening, the moment you do the access opening, first search and then check for the path, whether your path is straight, curved, pre-curved or bifurcated. So locating canal, you can use all these materials. DG16 is there. DG16 means David Green. Ultrasonic tips E4, either you can use of various companies are there. You can use either of Waldent, Woodpecker or you can companies ultrasonic tips are present. And dental loops also help you to find the miscanals and your microscopes also. So access opening related, all these kind of problems you find whenever you're doing access opening. So first you can see that under extended access opening will be there. Like you got the drop, but still you couldn't find the canal, or either you in search of the canal you did the overextended access cavity preparation, and when you are doing the overextended access cavity preparation, perforation is the normal cause you would have seen while doing the access opening. So mouse hole effect generally you would have seen in the premolar access cavity opening. So as I said, today I'm going to cover the main topic related to the cleaning and shaping biomechanical preparation in the root canal. So if someone asks what is the biomechanical preparation, is the kind of process of removing the debris and shaping of the root canal system to facilitate the disinfection and filling. It involves it involves both mechanical and chemical procedure to prepare the canal for root canal filling. Yeah, the moment you get the access or you find that number of canal and you find the glide path like till where you have to go, whether your canal is curved or not, after that only your main work start. First you should know the what is main the part what it covers, means what is biomechanical preparation. Biomechanical preparation is not like you just have to place the rotary file, you shape up the canal and everything. No, is the combination of two procedure, mechanical and chemical, which help to do two procedure. Means first, it help to remove your debris part, necrose part, and infected part. Second, with the help of chemical procedure, it remove all necrose part. Third, it help to shape up your canals. So, what are the objectives of cleaning and shaping of the root canal? So, as I said, first is removal of the pathogenic content. Second, creating a tapered canal. As I said, the mechanical procedure will cover, and it ensure the disinfect and filling access, and it also help to maintain the root structure. Yeah, if you won't do the proper shape up or in taper the canal, it you won't follow the anatomy of the root, then you end up doing the perforation. And also, if you do all these steps properly, then only your next step, that obturation, will go properly. Otherwise, you would have seen in some cases you would have end up doing the short obturation, or in some cases you would have seen you would have done end up doing over obturation. Over obturation only you can do when you don't know the working length and you try to do over instrumentation. Because of that thing, you end up doing the over obturation also. So in our general dentistry till now, whenever we read, write, or whenever we start doing all this endodontic procedure, we go through these three techniques. First is crown down technique, second is step back technique, third is hybrid, or means combination of both technique. If you ask, or if we ask someone like which technique we are using in our rotary files, it's a crown down technique. But most of the file system, they are following hybrid technique. Means Pro Taper Gold, a file from the dense ply, it's combination of the hybrid technique. But ground down technique, it's done by, like, if you ask me, I am using Oricam also, and Pro Taper Gold also with the this thing co-sponsored by dense ply. But thing is, like, both system has different technique. If you ask me which one is this Protaper is following, Protaper is following hybrid technique, and crown down is followed by Oricam. So these are the techniques various rotary system is following. It's not like we have to do the step back technique only. So what is the difference between mechanical and manual instrumentation? Manual instrumentation essential for the initial canal negotiation and patency, provides the tactile feedback for the complex anatomy and necessary for the bypass of the obstruction ledges, and lower the cost but greater the time investment, steep learning curve of the proper canal. Yeah. See, whenever you're doing, if you ask me how you're going, sir, doing practice and all, I am doing the combination of both techniques, means manual and mechanical instrumentation. Why it's essential? As it's written, it helps to first find the negotiation of the canal and patency, means path and number of the canal. Because with the help of the rotary files, it's very hard to find the number of canals or path of the canals, and there is a chance of breakage of your rotary files. Then second, with the help of your hand file or your manual instrumentation, you can feel the tactile easily. With the help of rotary, it's very hard to feel the tactile sensation. Bypass of the obstruction and the ledges, and it also lower the cost, but the only disadvantage is the greater time. Yeah, but you can, if you're using in hybrid mode, it's so the only at the initial level it's very at slower, means time duration will be a little bit longer, but later it catch up. Because the moment you do the BMP till apex with the help of your hand file, means imagine if I am doing BMP of the mesobuccal canal, and with the help of the K file, I try to prepare till uh, apex with the help of 15 number or 20 till 25 number K file, and then I proceed with the rotary file. Because once the your canal get loosened, it helps the rotary file to the shape up easily, and it also like produce lesser load on rotary files, so that it avoid the fracture of the rotary instrument later stages. Because sometimes what happen, you try to use directly rotary files and it end up doing the root canal rotary file fractures in initial stages. Also sometimes you would have seen, if you are using 4% 17 of the oricam, it end up doing fracture in initial stages, because of root constraint and resistance, it end up doing the fracture. Then mechanical instrument, as I said, yeah, it improves the efficacy. It maintains the original canal path in the canal curve and also help in the reciprocating motion and also predictable and reduce the canal shape. And also operator fatigue is reduced in this procedure. But as I said, like whenever you're doing pre-curve means curved canal treatment and you are doing for any canal treatment, better to start with your hand file so that there is a you can avoid the ledge formation, instrument breakage, and blockage also. So it's better start with first find the part with the help of your hand file, pre-curve the tip of the file, bypass it, reach till apex, try to loosen the canal, and then go with NITA instruments or rotary instrument. Yeah, it's clearly written in maintain the path. But if you don't know the path properly, it will also give the perforation in some cases, like in mesobuccal canal or in upper tooth also. So, what are essential things are needed when you're doing biomechanical preparation? So, in hand instruments, K file is needed, H file is needed, and reamers are very important in these kind of functions. Then, K file excel at the negotiation and also help in the enlargement. H file at the tissue removal and the reamer at the smoothing canal. Yeah. If you are asking about hand instruments, whenever you are using hand instrument, you start with K files. Don't rush for removing of the your pulp, because sometimes people they see the moment they open the chamber they see pulp is there. I have to remove with the help of H file. Remember one thing, H file is having cross section of circular shape, and once if it break because of canal restrictant or resistance, it's very hard to bypass because of its cross section. So first try to find the canal, and after with the help of K file, once you loosen the your canal with the help of H file, if any remnants is there, then you try to remove the remnants with the help of H file. Don't try to use H file at initial stage. Try to go use it later in later stages after the K file your canal is prepared either till 20, 15, or 25 till your working length, full length. Then only start using your H file. Don't try to use it at initial stage. And later, after using K and H file, you can use your reamers, which also smoothen your canals. Irrigation device. Various irrigation devices are present, like side bend needles are there to avoid the any kind of over irrigation. Ultrasonic tips are there. Activation systems are there to enhance the chemical disinfection by improving the irrigant penetration throughout the complex canal system. This system utilizes the super elastic nickel titanium alloy in the constant or the variable tapered design. They come in the single file system or multiple file system. So as you are, if you ask me which system I using, I am using either Pro Taper Gold or Neo Endo rotary files in initial stages. But if you ask me, it's better to use Pro Taper Gold because of its safety features, because the chances of fracture of these kind of portable gold files are very less if you compare with other company files. Then length determination with the help of apex locator is important, but it's only applicable when you're using your rubber dam. If you're not using your rubber dam, it's very hard to use your apex locator, because if your canals are wet, it won't give your perfect reading. It will give your false reading. So if you ask me, like how we are doing irrigation and everything. Till now, I said you're going to do first use your K file, H file, after that your reamer, and after that your irrigation will be there, then your rotary files, and your then little sealing. As I said, now sodium hypochlorite plays very important role. If you ask me how I'm using with the like ratio of sodium hypochlorite and this thing saline, I will tell you step by step. First thing, whenever you're using sodium hypochlorite in patient's mouth, try to do one thing first. Whenever you're using sodium hypochlorite, you have to first repair the wall defects. If imagine you're doing RCT for respected 4-6 and carious part was there in distal aspect. So remember first to overflow the sodium hypochlorite in patient mouth. If you are not using rubber dam, then it's better to first do the repair of the wall defects, what all there, whether it's distal, mesial, buccal, or palatal. So you have to repair the wall defect. After repairing the wall defect, it's very easy to hold the hypochlorite in the respective tooth, because if any wall defect is there, the chances of sodium hypochlorite to go in patient throat and it gives the irritation, and like patient won't give your best feedback or best response, or sometimes patient gets angry also while if patient inhale your sodium hypochlorite. So whenever whenever you are using sodium hypochlorite, the advantage is there. It's a coagulant irrigant of the choice, effective in the antimicrobial agent, excellent organic tissue solvent and lubricant, and effective really. Sometimes people ask me कि सर आप ये sodium hypochlorite and saline को mix करना चाहिए. If you ask me, it's no, we should not use, because people are thinking like if we are mixing sodium hypochlorite and saline, it's reducing its irritating property. No, but it's also reducing its effective property on the tissue. So it's better to use both things separately. Yeah, ratio may vary, means 3 times saline you use, then you can use your hypo, and then later you go for saline. So, but when you're using hypo, you try to repair your wall defects. After repairing the wall defects, then you use your hypo, and with the help of saline, then remove it, and then later proceed. You would have heard one term is there, 3D shaping and cleaning. It's nothing big thing, 3D shaping and cleaning. 3D shaping is like the more you activate your hypo, the more you get the lateral canal access. Means lateral canal get open up. So whenever you're using lateral 3D irrigation protocol, you have to activate hypo as much as you can. Now, if you ask me how you're going to activate your hypo, you can activate your hypo with your ultrasonic tips or sonic tapes, or agitators are available nowadays in market, or you can heat up your sodium hypochlorite with the help of your down pack that reaches up to 200 degrees Celsius, I know, but you can heat up at least till 100 degrees Celsius irrespective tooth. With the help of like heating up and increased temperature, sodium hypochlorite activates, and it removes the debris whatever there in the dentinal tubules. It helps to find the lateral canals. So these all our methods are there to activate your this thing, irrigating solutions. So manual activation, I said, with the help of K files, you can agitate and activate. We used to do in older days. Thermal activation, I said, with the increasing temperature. Pressure activation with your ultrasonic tips activation. Then passive activation we are doing, and laser activation as there. This thing, pad uh, name is there. With the help of that thing, you can use. So Chlorhex is available. Chlorhex you can use. Chlorhex is, it has a antibacterial effects by binding the hydroxide crystals with the combination of calcium hydroxide, effective against the anaerobes. And second, it also is the low toxicity compared to the sodium hypochlorite. So it's better to use Chlorhex in the cases if patient is having any toxicity problem in oral cavity with the sodium hypochlorite. Disadvantage is there, it is not having that much solvent action as you compare with the sodium hypochlorite. Discoloration is present with the help of Chlorhex, so better to use in minimum cases, and it's a bitter in taste and toxic. So this way I am following this thing, irrigation protocol. If you want to take up the photos, you can take up. So first irrigation will be there with the help of sodium hypochlorite 3% and vacuum, then clean it, dry the canal, and then after that you can irrigate with the saline. After irrigation with saline, again dry the canal, and again with the help of irritate, remove your smear layer and other debris. Yeah, these 5 stages are very important when you're doing irrigation. As I said, You started with sodium hypochlorite, you removed the wall defects, repaired, then you can use hypochlorite. Then you have to vacuum the sodium hypochlorite. What do you mean by vacuum the sodium hypochlorite? Means within the canal, you have to remove the sodium hypochlorite properly and then the dry canal. Now people ask me like how we are going to dry the canal. Generally, you would have seen that in our practice, what we generally see, the moment doctor say, "Arey, canal dry karna hai," the moment we hear these words, we take up our three-way syringe and dry the canal. Don't try to do all these kind of things because air emphysema, if it occurs, then patient will have severe and traumatic pain. Means like patient won't bear and he will keep calling you like, sir, you would have maybe you would have done the treatment, but still I'm having pain, swelling, and irritation in my respected tooth or respected tooth apical area. The moment you want to dry the canal, once you vacuum your sodium hypochlorite with suction tips, try to dry with the help of paper points or so many sideway needles are there. With the help of that also you can dry the canals. Later, irrigate with the saline and same procedure again follow, dry with the paper point and then again vacuum the saline and water and then again use the EDTA. Now question is that which kind of EDTA we have to use, whether liquid or your gel form. Many people they say if you won't find the canal, keep the EDTA. If you won't find the apex, till you won't reach the apex, keep the EDTA. Don't do all these kind of things. Because if you are doing all these kind of things, you are necrosing your dentin. And in later stage, in future, if patient get some hard food or something, if they bite, they end up doing vertical fracture or root fracture. Because of dentin necrose, that the chances of fracture with the help of EDTA. So no need to keep EDTA for longer duration, first thing. Now, second thing, when you have to use your liquid EDTA, at initial stages, the moment you negotiated the canal, you reach the apex, that moment you have to use your liquid EDTA. And then in between later stages, when you are doing, means like you would have prepared the canal with the help of H file, means hand file, and then later when you're jumping towards your rotary file, you can use a gel form EDTA, and then later while doing means like final backup, at that moment at last round you can use your liquid EDTA to remove the all remaining dentin. Though so you have to follow like this. It's not like liquid EDTA we can't use. Liquid EDTA is must when you are doing initial BMP. At in between you can use your gel EDTA when you're using rotary files, and at last when you're winding up, that time you can use liquid EDTA and to clean up all debris. So as I said, all this procedure, yeah. If you ask me where I use Chlorhex, I use Chlorhex in external root resorption cases where you have to remove your flap and then irrigate properly and remove the debris and wash the means respected area with the help of Chlorhex. Because there you can't use your hypo because of toxicity. That is your Chlorhex helps and it's very effective in external root resorption cases. Rotary files. Rotary files endodontic is the method in which the doctor utilizes the electric handpiece to perform the procedure. Electric handpiece allows the doctor to clean and shape the canal faster and easier than using the hand file. Because it's electric, there is no drill noise. These instruments often made up of nickel or titanium, so they are extremely durable, and this makes the whole treatment experience much more pleasant. As I said, I am using three system. From one of them is Neo Endorotary file system, and their procedures are respective. So these are the parts of the rotary files. If you see, which, like markings will be there in like few company they gives marking also. Like it's easy when you're doing rotary files, it easily depicts like you reach till respective working length, you have to take care of your apex there. A tip size indicator is there. It helps to identify the rotary files while using rotary file, like while picking up the rotary file from our endo box easily, because like it's not like we contaminate or every rotary file if you don't know these kind of markings. So in Oricam, if you're using one line is if red color or respective red, yellow, or any blue color is there, means it's 4%. If it's double ring is there, then it's a 6% taper. These are the various type of rotary files are present in our practice. We are using of different cross section. So the moment you find the glide path, as I said at first slide, like first you have to scout and then glide path. The moment you find the glide path means you reach till apex with the help of edge, your hand file, you did the full length, working length, BMP, everything. Then you can use your new endoflex file rather to jump for long number this thing hand file is better. You can use even with the after doing BMP till 15, you can use your neo endoflex glide path. It's help you to increase the taper step by step. As you can see in the screen, it's written first 16 13 2% taper, then we go for 16, and then we go for 19. Later slowly it increases up, and then you can go for your respective 4%, 25, 6%, 28, 6%, 25. New endo K file and new endo C pro. New endo K files are the initial files like a K file of various company. It helps to negotiate the initial canals. But imagine if you won't find these canals, then at that moment you need the stiff files or calcify canal files, which help you to find the calcify canal, or which help you to find the path in the calcify canal till the apex you reach. So you can use your K file also. Even you can use your ultrasonic tips are present in the your kit also in your clinic also, which help you to rectify the blockage of the canal or to find the number various canal present in the respected tooth. So first, if you ask me what we are going to do, first is the access opening we do, then glide path as I said. After that, one these three step is there. You can, if you want to take photo, you can take. First, create an optimal axis. The moment you find the optimal axis, then straight line axis will be there. Remove the all coronal interference if there, and while preserving the tooth structure. As I said, while preserving the tooth structure means whichever tooth structure is present, build up and everything, repair it, and then proceed with next step. Then initial, as I said, smaller number head file is needed. EDTA lubricant to scout the canal and confirm the patency to the working length. Again and again, I am saying, because nowadays people skip these step only and they end up doing the file fracture. The moment they open, they see a canal orifice is there. We start using rotary file and we end up doing file fracture. Whether you're using far better brand or whether you're using very worse, the condition will be same, file fracture. So use your hand files, then EDTA lubricant, scout, and then check for glide path means patency, whether it's going or not till apex, and then proceed with your glide path preparation with the help of your hand files, and then later followed by rotary files. So if you ask me how I am going to, I am following the sequence. You can see on the screen. First, I try to find with the help of K file or new endo hand files your canals, number of canals present, and later I did do the coronal flare up, and then after that doing coronal flare up, you can do coronal flare up even with the help of your ultrasonic tips. Coronal flare up, the file is of more taper, either 8% or 12% taper. Then later you can go for glide path, then narrow the canal. In narrow canal, you can go for 4% 20, then 4% 25, and then later step by step you can proceed with respective rotary file. I wanted to show in this slide mainly is like initially I started with K file, and then later I started adding these files. So irrigation and recapsulation, whenever you're doing irrigation part with the help of sodium hypochlorite, it's very needed. Like after doing sodium hypochlorite use, you have to clean it up with the saline and dry the canal. Try to use sideway needle position 1 to 2 mm shorter of the working length, because if you are putting your instruments till the working length, means irrigating instruments till the working length, the moment you put up the pressure, it's to the penetration of your irrigating solution in the canal, and later it gives the irritating means experience to the patient, or toxic experience to the patient in lateral procedure. So to avoid these kind of things, you can use sideband needles. And as I said, how you're going to activate with the help of sonic or ultrasonic devices, you can enhance the penetration, and you can proceed with the your ETA, and then recapitulation is important. So first, after that, before ending up like reaching to the master code, confirm the final preparation, inspect the file integrity whenever you are using, yeah, whenever you are using file, the moment you place in your canal, again and again, whenever you're doing BMP, check for the tip if any breakage is there or not. If any tip breaker is there, it's better to retrieve or bypass at that moment only. A later stage, because of apical push, it end up doing the blockage, and it's very hard to difficult to remove or bypass the K file or any instrument through the fracture fragments. If you ask me tips for the rotary files, first establish a proper glide path, use the recapitulated motor settings, whichever is giving according to company, employ the proper instrumentation technique, and regular file inspection is important. As I said like few seconds back only, carefully examine the files for the sign of the unwinding, distortion, or metal fatigue after each use, and discard the files that shows any visible defects to the prevent intercanal. There's a case study. So you can take up these points are very important. File selection is important. Choose the appropriate file size, length, taper of for each case, using the correct file with the minimize the risk of the canal transportation. Second, gentle pressure should be applied whenever you're using endo files. Don't try to avoid excess forces, as it can lead to the file breakage or unnecessary dentin removal. Then frequent irrigation is important. It's not like, yeah, you would have done irrigation with the help of filing with the help of H file, hand file, rotary file, and you are waiting for the last stage key, like after doing everything, then I agree. No, after each instrumentation, you should do the irrigation, because if any debris uh, uh, transportation will be there in the canal with by doing BMP, then it will be very difficult to remove or difficult to rectify the defects. Then file movement is very important according to manufacturers or basic techniques what we follow in our practice. Recap, re reciprocating motion is very important. Whenever you are succeeding with larger number file, try to do after BMP with the larger number by 2 to 3, and again come back to the smaller, because if any blockage is there, it rectify that thing. So how often do you use your rotary files, endo files? If you ask me, endo files should be inspected before every use and after every use. Any sign of deformation or damage warrant immediately disposable. No need to proceed. And sometimes people ask, like, in how many patients we can use our rotary files? It's a myth. It's a number of canals. It's like, if you ask me, like, you can use, ideally, if you are using any kind of rotary files, it's better to use your rotary file in 10 to 15 canals, not patient. So these thing varies by number of canals, not number of patient. This kind of myth happens because sometimes I goes to some clinics, they tell ki like, sir, I use in 15 patient and it didn't break, but some people say I use in 15 patient, it broke. So it's not the number of patient, it's the number of canal you use your rotary files or your hand file or endodontic files. So how to prevent the file breakage during the treatment? Apply light control pressure using correct file size, and avoiding the excessive bending can reduce the risk of the file breakage. Can endodontic files can be used the pediatric dentist? Yeah, we can use. Many are there in company. Are they are contraindicated for you? Nothing. It's like that. Can endo files can be sterilized using? Yes, cold you can use. And can endo files can be reused after single use protocols? But if you ask me single use, then infection control must be followed. So after completing the basic procedure regarding biomechanical preparation, and endodontic this thing irrigating part. I am like going to cover one more part in this only, like the mishaps related to cleaning and shipping generally we face. So perforation you would have seen, ledge formation is very common when if you're not pre-bending your file tip from the apex and then canal blockage and then separated instruments. As I said, if you use larger number of files at initial stage, you end up doing the ledge formation. So if there is no straight axis, then ledge formation chances are more. And pre-curve canals, the ledge chances are very more. And in bull eye lesion also, you can find the ledge chances are, as you can see, the bull eye lesion, the root must be more curved towards the lingual side, and because of that, the chances of ledge formation is more if you won't didn't do the glide path properly. So how you're going to recognize when root instruments cannot be placed till the working length, full working length, means at initial stages or at the initial X-ray you would have seen the root length is showing different, and but your instrument stuck in between 2 to 3 mm shorter than the root length. In that cases, or there is a loss of tactile sensation, means any resistance was faced we were facing at initial stage, but later stages we couldn't find. Then sensation of the tip of the instrument hitting the against the solid wall. And radiographic indication, as you can see in many cases or in your practice, radiographic indication is the last ultimate resort to find the error. How you're going to correct? First, recognize the ledge and then provide the unobstructed access. After finding the ledge, means obstructed access, try to remove the existing filling material. After removing the material, enlarge the canal orifices till your ledge is there first. I'm saying till your ledge. Imagine your root length is 19 mm, you got ledge at 17 mm. First try to enlarge your canal till 17 mm, then try to bypass or start doing instrumentation once you enlarge the canal after doing BMP till 17 mm length. So after negotiating, then pre-bend your file, then bend the tip away from the ledge and towards the suspected continuation. Then wash winding motion will be helpful to find the original path, and if you can find the catch point easily if you enlarge the canal till the ledge. So the moment once you find the catch point, locate, bypass, and then follow for the treatment. The best solution for the ledge prevention is accurate interpretation of the diagnostic radiograph, curving of the instrument, and no forcing of the instrument. Awareness of the canal morphology throughout the instrument is very important. Safe ended instrument at the night eye should be there. So perforation, you can see if you won't do the BMP properly according to manufacture or canal anatomy, you end up doing perforation at cervical and middle third or apical third. After getting these kind of cases, you can see sudden bleeding in the patient mouth. Radiographically, it will be seen easily. If you ask me, stripping is the lateral perforation caused by the overinstrument throughout the thin wall. Yeah, it's correct. Because if you don't know the means file use or sequence of the file use, you end up doing the proximal stripping of the interradicular area with the help of instrument. And it's very like wrong thing, like you if the moment you do the lateral perforation or interradicular area stripping, because the moment you do the interradicular area stripping and later after even after knowing that you did the lateral stripping, you can end up doing the tooth fracture in later stages. So how you're going to correct? If the perforation is small, you can seal form from the inside. If large, it's first seal from the inside and then later surgically exposure is needed and repair with the help of MT. Or mid-root perforation is there, first obturate and then surgically you have to repair. So if you ask me how you're going to repair, first diagnosis the part where you have to do the perforation repair, then cleaning and disinfection of the respected area and perforation repair is important. So new methods for the separated instruments from the root canal is there. So these four are the main points generally cause the endodontic rotary file fracture or hand file fracture. First is torsional stress. Occur when the tip of the file bind in the canal while the shank continues to rotate and leading to the twist and eventually the breakage. So as you can see, it's written clearly like the moment your tip of the rotary file stuck, you would have felt this thing many times. Your tip of the instrument or rotary instrument is stuck at the peg, but you still try to rotate. At that time, your chances of rotary file breakage is there. Then same way is the flexure fatigue. The result from the repeated stress on the metal as it rotates in the curved canal, similar to the bending or wire back or forth until it breaks. Instrument overuse. If you continuous using as a number of patient, as I said at earlier slides, it's not number of patient, it's number of canal. So if you're using any night eye or rotary files, if you're using multiple times, it increase the risk as they may not show the visible sign of fatigue before falling. Anatomically challenges. Narrow and calcify and severely curved canals increase the stress on the instruments. So how you're going to prevent the file fracture? If you ask me, limit the file use and copious irrigation is important, and inspect the file regularly whenever you're using the files, rotary files. Establish the glide path at initial stage. I said speed and torque according to the management is important, and avoid the forcing the file in the apex area. So this will be your reaction the moment you see these kind of X-ray in your clinic. When you have done these kind of, you are happy when you see. If you won't see these kind of pictures, but if the moment you see these kind of pictures, it gives this reaction only. So how you're going to correct all these things? So three kind of methods are there. Peripherally filing technique is there. Newer system spinal tap needle is there, and ultrasonic tips. In my practice, if you ask, I am using ultrasonic tips. Various company ultrasonic tips are present, but I am using woodpecker ultrasonic tips. It helps me to remove, irrigate, enlarge, and many procedure with the help of only ultrasonic tips I am doing. So E4 file is there, ultrasonic file is there. With the help of that we can remove our any filling material or obturating material from the canal while doing the re-RCT. Same way your E4D help to coronal flare up, and E66 is the dynamic rotary file. If you ask me, it help to use in the irrigation, it helped to use in the retrieval of the separated instrument, it helped to use your post and core, this screw post or fiber post in post and core cases. And E11 is there to it help to polish the apex area from the retrograde preparation of the root canal and the retrograde filling also. So these are few of my cases I have done in my clinical practice. You can see file fracture was appreciated in the middle third of the root. With the help of ultrasonic tips, I tried to activate the ultrasonic tips, and with the vibration techniques, it came out, then sealed it. And with the help of peripheral technique, when it reaches till the coronal portion, with the peripheral technique, I removed, and then obturation was proceed. Same way in this case also, you can see over file fracture was there. After file fracture was appreciated, we tried to bypass, but with the help of ultrasonic tips, circumferentially filing was done, and the rotary file came out. It means the separated instrument came out with the help of your rotary file or your ultrasonic tips also, and then obturation was occurred. So this is also one of my cases for retriever. Same way. So canal blockage. When canal suddenly does not permit a working length to advance till the working length, then the situation referred as a blockout has occurred. Buchin pointed that blockade occur when the file compact apical debris into the hardened mass. Fibrous blockage occur when the vital pulp tissue is compacted and the solidify against the apical constrictor. How are you going to recognize? If you ask me, when confirmed with the working length is no longer attained, then radiography along with the instrument. Correction. Recapitation with the chelating agent and the smallest file in the quarter turn technique. If the blockout occur at a curve, recurve the instruments and gently recapitulate and copious irrigation is important. What is 15-10-8 technique? It's a technique to initially use for the canal preparation in the endodontic procedure. First, try to find the canal path with the help of either 10 or 15 number, then recapitulate and then proceed with your larger file. Don't try to use your larger number files. So prognosis. Prognosis depend on the stages at which the blockout occur. If the canal has been clean and shaped, the little or no effect on the prognosis. If not clean before the blockout, reduce the prognosis. Prevention. Frequent irrigation during the canal preparation is there, then canal lubricant must be used. So you can see the canal blockage was there. Then with the help of ultrasonic tubes, the canal blockage was removed. We reached, later we got to know that bifurcation was there. So I try to cover all these kind of procedures and techniques and failures in my seminar today. So thank you so much. And if you have any doubt, you can ask me.
Thank you, Dr. Yash, for the wonderful lecture.
Thank you so much, sir.
If anyone have any queries, they can drop the message in the chat box. Dr. Yash, someone has asked that the difference between ninja and truss axis.
Okay, ninja technique is the technique in which that we won't do the proper ideal access opening. We try to just do the one orifice open with the help of like small narrow opening, and we reach till the interradicular area and we try to remove the pulp chamber and this thing irrigate and do the obturation. But the very like if you ask me disadvantage of ninja technique disadvantage is that like it's very hard to remove the dentin debris or radicular debris in the radicular area present, because the irrigation won't be proper. Chamber is not that much wide open to irrigate properly, and if any remnant remains there even after doing very nice irrigation, the patient might have pain at later stages. And other the technique you asked me, tough technique is like the wherever you get the access, means wherever you are seeing the carious part is present or wherever you are seeing any disease part is there, you try to do the access opening from the respective area rather doing the ideal access opening. Imagine you are doing access opening of the canine and you see the cervical area is diseased. So in that cases, I try to do the access opening from the cervical area only, rather doing my access opening from the cingulum area. So I try to means save my sound structure of the tooth, and then remove the carious part from the disease area and try to get access from the respective area, and then I try to proceed. Ninja technique, it's only applicable if you ask me if means like single rooted tooth only, but people try to do in your molar also. But in molar cases, if you try to do like if four canals is there, you try give the ditch, four ditches, you got the canal, you did the obturation, but what about the interradicular debris or interradicular remnants were present? Because irrigating solution won't reach properly in that area, and if there any remnants will present, then pain will be there in that area. So ninja technique is there, it's helpful for for saving the tooth strength, but it's very like traumatic or painful also if you won't remove the debris properly in ninja technique.
Thank you. The next question is that how many times sodium hypochlorite should be used?
Sodium hypochlorite is like is if you ask me how many times we have to use sodium hypochlorite in one patient or one canal, we should ideally 5 to 10 ml. But it's a kind of ratio, means 3 times saline you have to use, then try to use sodium hypochlorite one time, and then you go for again your sodium hypochlorite, and again 3 times, means 3:1 ratio you can use your, your sodium hypochlorite, and try to activate as much as you can activate your sodium hypochlorite.
Okay. The next question we have is which EDA to use and when?
Yeah, I said this thing, which EDTA to use when. I said liquid EDTA, whenever you're using two types of EDTAs are present in market, liquid and gel form. When you're doing initial preparation, means at starting you are using, don't try to use a gel form EDTA because it necros your dentin and whatever debris is there. So it's better to use your liquid EDTA. It reaches till your apex also. It flow easily. The moment you do enlarge the canal at certain level of mean size, then try to use your gel form EDTA. So liquid EDTA at initial stages, in between your procedure, you can use your gel form EDTA, and then at later stages to wash out all debris, you can use your liquid EDTA.
Thank you, Dr. Yash. I hope all the queries of the participants has been cleared, and it was a very nice and wonderful lecture. Thank you.
Thank you.
Concepts. We welcome you, sir.
Hello, I hope I'm audible.
Yes, sir, you are audible.
Yes. Okay, is my screen visible?
Yes, sir, it's visible.
Okay, doctor, are we good to go?
Yeah, sir, we're good to go. You can start.
Yeah. So, good afternoon, everyone. Respected colleagues and my dear friends, it's a privilege to be part of this scientific forum and share the insights on this very trending topic of obturation and bioceramics and MTA. So, today we'll explore MTA bioceramics and the contemporary bonding concepts, which are redefining the way we are approaching the obturation, not only the obturation, but also the cleaning and disinfection of the root canal systems. So root canal system is a highly complex 3D dimensional network containing fins, isthmus, lateral canals, accessory canals, apical deltas, dentinal tubules, and whatnot. But one thing we know that all of them cannot be disinfected and instrumented for sure. These are the SEM images where we come to know that only 30 to 60% of the canal walls are not being touched at all by the instruments or the files which we use for mechanical preparation, and that's why the residual bacteria and biofilms are they persist there. Then why does the seal matters anyway in endodontics? Because there are multiple pathways which lead to the pulpal inflammation. All of those pathways should be blocked in order to achieve a endodontic success, in order to achieve endodontically successful outcome. We'll try to understand this by a simple informatic. In case of a heavily infected root canal system, microbial density of the biofilm is very high, and also its structural maturity is also very high. Even after trying to clean the system, there will be still some amount of bacteria which will persist. So we try to clean them and obturate the canals. After even obturating the canals, coronal and apical seal, which will have the uh, exudates and the saliva, which can feed the nutrients to the bacteria, can lead to reinfections. So that's why the sealing of the apical and the coronal end matters. So now, what is the biological basis of this endodontic success? First, we used to talk about hermetic seal. Hermetic seal. Why hermetic seal? Because the primary aim of the root canal is to obtain a hermetic seal. However, in endodontics, this term has been wrongly used. The tooth is surrounded by oral fluids and microflora. Hence, the term fluid tight seal is commonly the referred term. Success of root canal depends on obturation of the canal space. For many years, lack of obturation of root canal space was considered as the cause of endodontic reinfection. Now the debate remains, what is more important, the apical leakage or the coronal leakage? So there was a systematic review by Mr. Gill where they came to the conclusion that there is no significant difference in the odds of healing between these two combinations. What that implies is basically both of the coronal and the apical seal matter equally when we talk about the endodontic treatment outcomes. Various studies, like groundbreaking studies of Saunders and Saunders et al., Trey and Trope, which we have been studying for decades now, they broke the endodontic community because endodontic community was more focused about obturations and their puffs and their sealers and the lateral canals. But what they said is that more than the apical, the coronal seal matters. We'll see the statistics of the Ray and Trope study, where they came to the conclusion that quality of endodontic treatment is poor when the coronal and endodont treatment are performed below the average, and they are good when both of them are being treated sufficiently. But what should be matter of concern over here is that the quality of corneal restoration, when it is good along with the paired quality of endodontic treatment, which can be categorized as poor, the success rate was only 56%. Then we come to the evolution of endodontic sealers. There are various types of endodontic sealers in the market right now. They started right from the ZOE to silicone to epoxy to salicylates to GICs to ionomers. But there are certain set standards in the industry for the sealers. That is, according to the ISO or the ANSI norms, these are the set standards which were established back in 2012, which govern the quality of the sealers which we have in the market right now. Film thickness is supposed to be less than 50 micromm. Solubility should not be more than 3%. Flow rate cannot be greater than 17 mm, and the radio opacity should be minimum to 3 mm of alumina. Now coming to the good old sealer, that is a ZOE sealer. ZOE sealer has the advantage of the lowest shrinkage. It has high antimicrobial activity up to 7 days. It has very less post-op pain. It is economical. It has around 5 to 8 mm of alumina radio opacity, but the problems are numerous and huge, which is that it has a maximum leakage over time. It gets dissolved. Highest solubility of 2.5% around. Also, we know eugenol. Eugenol is a nerve conductant irritant, and also it stains the tooth with time. Now, the gold standard which we had was the epoxy-based sealer. Epoxy-based sealer is the AH plus sealer, good old sealer. Basically, it has excellent solubility, less solubility of 1.4%. Film thickness is very good of 26 mm, excellent flow and penetration into the NT. Next comes the silicon-based sealer. Silicon-based sealer have the lowest solubility of around 0%. Water sorption is also very less, and it has lowest cytotoxicity. But the issues are it is hydrophobic in nature, it has poor wettability, there is no chemical bond, and there is very low radio opacity. Now, during this evolution phase of sealer was going on, Torabinajad came around and he dropped this bomb MTA into the world of endodontics, and which is being evolved till date. So now there is this confusion amongst us that what is MTA and what is bioceramic and what is calcium silicate. All of them belong to a single family of calcium silicate sealers or calcium silicate cements or calcium silicate putties. Now, what is the difference? Till the time MTA was made, there was not enough of biomaterial engineering advancement so that we could have those nanoparticles of those same material. Now, with the advancements and with the material application requirement, we are able to have that same MTA properties in a very good flow with a very good sealability and a very superior handling properties. So the generations of MTA are such that first generation was the classic Portland cement, which was derivative of a heavy metal oxide, which are longer setting hours of 3 to 4 hours, which used to have tooth discoloration because it had bismuth. Second generation adapted to the commercial size, reduced the particle size, heavy metals were reduced, cytotoxicity was reduced. Third generation, nanotechnology was integrated. And radio opacifiers like zirconium oxide was added, and even the setting times were reduced. Then in fourth and fifth generation, resin was added in the calcium silicate formula for high performance biomaterials, and also it had some dual cure properties. Now, what is the hydration reaction sequence of bioceramic and endodontic sealer? Like what does happen? How does it sets and how does it makes that hydroxyapatite? What is that feedback loop? So basically, there are three stages: stage 1, stage 2, and stage 3. Stage 1 is the initial component and moisture intake, where the bioceramic components are being placed inside, and the dentine moisture acts on it and makes calcium silicate hydrogel along with calcium hydroxide. Now, this calcium hydroxide makes an alkaline environment, increases the ALP, which in turns, while combining with calcium phosphate and calcium hydroxide with water, makes hydroxyapatite. And this is a self-perpetuating cycle where water is used continuously for its hydration. Now coming to the classification of bioceramic sealers, calcium silicates and calcium phosphates are the two types of bioceramic sealer based on composition, just to keep it simple. But there are various brands and various types of sealers which we have. Apart from the calcium silicates, which are pure MTA based and calcium phosphate based, there is also third type of sealer, that is a dual action brands. Calcium silicate and calcium phosphate sealers. The primary mechanism is hydration reaction from calcium silicate gel is in calcium silicate brands, and in calcium phosphate base there is enhanced crystallizing structure which mimics the hydroxyapatite. Based on setting, there are premixed and powder liquid, which is bioroot flow and bioroot RCS, just to give examples of it. Then based on clinical use, there is sealer and repair material. Based on consistency, there's injectable and putty. According to clinical preferences, they can be used. Now, based on generations, first generation, there were no impurities, no bismuths, only smaller particle size. They were a little bit expensive at that point of time. They are less radio opaque, so they don't look as good as our AS plus obturations on the radiographs. They have longer setting times and the tips are very high vestige. Then coming to the second generation of bioceramic sealers, which have great radio opacity, extremely flowable, which can be downpacked or can be heated, but they're a little bit more on the expensive side. Now, this MTF Filapex, Reco Gatafolo, BioSeal, SS White bioceramic sealers are not actually the pure bioceramic sealers. They are somewhere in the between of the epoxy and the salicylates and this bioceramic seals. Now coming to various studies which have been there, that what are the advantages of bioceramic sealer? That endodontic sealers, specifically iRoot SP, has showed more pronounced antibacterial effect when compared to AS plus sealer against E. faecalis, lactobacillus, and Pseudomonas. Clinical outcome. This is the only like the first pioneer randomized control trial on bioceramic sealer. It was a retrospective analysis which showed that non-surgical root canal treatment with single cone bioceramic sealer was equally efficient as the downpack epoxy-based obturations. Then are premix calcium silicate-based endodontic sealers comparable to the conventional materials? This was a systematic review by Almeida, where they found that the results were similar or better than the conventional endodontic sealers as observed in vitro and in vivo animal studies. Now, what are the advantages? To name a few, it has excellent biocompatibility. It causes minimal inflammatory response and it promotes the healing. It is bioactive, releases calcium ions and forms hydroxyapatite, which encourages the hard tissue formation. It has superior sealing ability, chemically bonds to dentine and gutta-percha. It is hydrophilic, sets in presence of moisture. It has minimal shrinkage, high alkaline pH, good dimensional stability, excellent radio opacity when we talk about Cerasil and all, osteogenic and cementogenic potential, and very low solubility after setting, which ensures a good long-term outcome. Now, this is bonding from sealer to dentine is good. But if we use bioceramic impregnated gutta-percha cones, we can also solve the problem of sealer to GP interface. They can also be termed as a monoblock then. This is the scanning electron microscopic image where we can see AH plus and gutta-percha. This interface, this white line which we can see, is basically the poor wettability of the sealer. And this is the bioceramic sealer and the gutta-percha. You can see it has merged seamlessly with the dentinal tubules there. These are the SEM sections of the middle sections of the obturated root, showing root canal penetration to dentinal tubules, obturated canals with AH plus at 24 hours, 7 days, and 4 weeks respectively, and also with endosequence bioceramic sealer. We can see the penetration depth is great, and also it keeps increasing with time. Now coming to the fracture resistance comparison, the fracture resistance has been found seemingly high when the bioceramic impregnated cones are used when compared to the normal gutta-percha which are being used regularly in the market right now. Now, what are the disadvantages? It is very difficult to retreat because it bonds to the dentine. It has a significantly higher cost when compared to the other modalities. Technique sensitive obturation is with bioceramic sealer. It has a limited long-term clinical evidence. It is a longer clinical setting time of around 3 to 4 hours. Potential for discoloration, difficult post-stage preparation, requires moisture for setting. It has limited compatibility with some retreatment systems, and it has certain handling characteristics which can be technique sensitive. Now, this is also an issue. The MDA, which we can see, used to discolor. Recent bioceramic materials don't have this issue. Then comes the sealer extrusion. Whereas it has been shown that AS Plus is also equally biocompatible, but to other sealers. But when compared to bioceramic sealers have no significant effect at all in any of the sealer extrusion cases. This is a case where huge extrusion of the sealer can be seen. But this is the pre-op and this is the post-op CBCT. You can see the lesion has been healed and the sealer, which was pushed beyond the apex, has seamlessly merged with the bone because it is highly biocompatible. Now, what are the different obturation techniques which we have? We always aim for the monoblock effect. as we have been taught since our BDS days. So to aim for a primary monoblock effect, only one root canal filling material can be placed, but we have to place a matrix and a carrier both. That's why we were having a secondary monoblock till time. Now this is a lateral condensation obturation where GP is there, resin and ZOE sealers are there. Eventually, with the 2.5% of solubility of ZOE and 0.7% solubility of resin, this matrix dissolves and only this GP cones are remain. In vertical condensation obturation also similar. We try to push the GP and not the sealer. So it is prone to leakage again. Single cone obturation with ZOE and resin can be categorized as a clinical crime because there is huge leakage possibility in there. Whereas when we talk about bioceramic sealers are supposed to be obturated with a method called as hydraulic condensation. Now, what is hydraulic condensation? Why gutta percha is always needed in hydraulic condensation if this material is so good? Because the retreatability of bioceramic sealer is very less. So that GP will act as a pathway to the apex if needed to be intervened later on. And also, in hydraulic obturation, gutta percha is the condenser and sealer is the filler for the technique. It allows the length management, it pushes cement to the space where it is needed, and it also allows the revision if it is needed. Then coming to the sealer placement techniques. It can be advanced method or beginner method as I categorize it. In advanced method, basically this is just a case of canal confluence where you place your tip in the middle third, cervical to middle third, not beyond that. A very high magnification should be used for this to avoid the inadvertent sealer extrusion. We can see the excellent flow of this sealer. This is also another technique where a self-locking tweezer can be used to hold the GP. The GP is placed inside the canal with the tweezer of the operator's hand, and assistant can use that ultrasonic tip over the tweezer so that the sealer is agitated inside and it is sealed hermetically. Now, hydraulic obturation can further be divided as passive and warm compaction. Passive hydraulic, this is first we take the master cone as we do always. Then we place the sealer at the middle third, upward to the cervical third. We remove the vapor lock. Due to the vapor lock, there is always some amount of dentine which is devoid of the sealers and irrigant. So that should be taken care of during irrigation also and during obturation also. Now, this is the beginner level of obturation where you place the biceramic sealer on the tip of the GP and you push it inside. You can see with the flowability of the material, the lateral and the apical part has also been taken care of. And you just shear it off. Now, what is heat activated? You check the plugger fit as we take till the middle third only, not till the apical third. After taking the heated plugger hit, check, we place the sealer and the GP as shown previously and we downpack it. After downpacking it to middle third, we wait for around 10 seconds for to cool down and then we heat it again. Yes. And then it is being backfilled. So when we compare the warm hydraulic compaction to the cold hydraulic compaction, we can see that warm hydraulic compaction has been better because even the GP has been pushed. But so not all bioceramic sealers are able to sustain that kind of heat which we place with a downpack. The sealer might change its property. So the powder liquid sealers, which is BioRoot RCS, has a very low heat stability. At 77 degrees Celsius, it sets immediately. The premix standard, which is ES plus bioceramics, sadly not available in India, shows moderate heat stability, and total fill bioceramic high flow has a high heat stability, so can be used with warm vertical compaction. But also the Cerasil of Metabio also has a good heat stability, so can be used for warm vertical compaction. Now coming to retreatment of bioceramics, there is buzz about this that bioceramic sealers can't be retreated because it gets penetrated into the dentine and all. But this is a BMC Oral Health article of 2021. These are the reconstructed microcity images showing effective removal of bioceramic sealer with PIPs after obturation, after mechanical retreatment, and after PIPs assisted irrigation. So basically, retreatments can be taken care of with bioceramics also. Now coming to the snippets from the operatory, the clinical cases which we will talking about. This is the case where lesion is being seen, retreatment case basically. Um, this MB2 was missed previously, so the lesion was formed over here. It was negotiated and obturated. This was obturated with bioceramic sealer. Then coming to another case of retreatment where periapical lesion and a separated instrument is seen. This instrument was taken care of. The canal confluence was seen. It was confirmed with the paper point. You can see the paper point. Then bioceramic sealer was coated as shown previously. GP plug was made and it was thermoplastically backfilled. This was the obturation and this is the follow-up. So it's a good periapical healing and symptomatic relief for the patient. This is another case of retreatment where a perforation was there. This was a foreign body, gutta pacha inside the perforated area and the separated instrument along with a huge periapical lesion also. It's a fairly young lady which came into the operatory, so we gave a uh, full down effort to save that tooth. This is the foreign body which you can see after removal. There was continuous bleeding, so we degranulated it. After this degranulation, complete hemostasis was achieved, canal projection was done. MTA, rather than MTA, bioceramic, no, biodentine was used over here because I wanted to complete the retreatment part and the perforation repair part in a single appointment. So biodentine helped me with that. So this was after the setting of biodentine, I placed the RMGIC liner over it, removed the instrument. Hydraulic obturation was done, beautiful apices are being sealed over here. And this is the magic of bioceramics. In 12 months follow-up, complete healing has been seen. The periapical lesion is resolved. The furcal area has regenerated its bone. This is the third case, again of retreatment, where you can see the instrument is protruding beyond the apex. So now, while retrieving it beyond the apex, you can see I had to trough till here. So it kind of increased the apical foramina and distorted the apex a little bit. So I didn't want to take any chances, so obturated again it with biodentine and in same appointment did a post-anchor build-up over it. This is a case of external apical root resorption where working length was taken with laser. We disinfected the canal thoroughly. So due to the extreme resorption, which can be seen till middle third of the distal root, we planned for a bioceramic obturation with the distal root and a normal bioceramic GP obturation in the mesial canals. Here we can see wonderful periapical healing is seen over here. This is a case of dense. We started it with non-surgical approach. Patient was having pain and swelling. Patient came with acute apical abscess of the diagnosis of acute apical abscess. So we obturated it with MTA over here. But the patient had persistent signs and symptoms. So we had to open it up. So after osteotomy, root resection and curettage, this is a clean image of the root apex. After staining, we found these two little canal openings in the apex, which were connected by an isthmus. So we prepared it retrograde and we filled with it MTA. This is the bone grafting, suturing, and the post-op exit. Now there's been with advancement of bioceramic materials, the retrofill protocol has also been updated. This is the bioceramic sealer and this is the bioceramic putty. Both are bioceramic and both have been used for apicectomy specifically. Now why? First, we prepare the cavity, we remove the GP from here. Then we used to place a bioceramic sealer and we used to close it. But now when we have putty materials, it has better handling properties. It has less washout resistance. So basically what happens is it is a very moisture sensitive environment. So we want something of high density over there. So putty helps to seal the sealer fluently inside the canals. This is a case of a 8-year-old pediatric patient which was referred to us. This is a periapical lesion. Again, is a broken instrument at the apical third. Patient was having an extraoral fistula. The referring doctor tried to manage it conservatively with medicaments and systemic antibiotics, but didn't help. So we visualized the uh, separated file and we removed it with ultrasonics and loops. This is post removal, working line determination, and we obturated it with biopsy repair by Angelus and beautiful clinical follow up. Just after 15 days, the fistula healed on its own. This is another interesting case. It came to us with a CBCT referred by a doctor that a persistent sinus after post-anchor was there after 1 year of crown placement. We took a CBCT and we thought that this apical third of the root has been fractured due to the post placement or the aggressive post place preparation. But to our wonder, if you can see this clinical image, there is bone resorption and also a dot, black dot, which can be seen. Basically, this was the root perforation inadvertently happened by the treating doctor at that point of time during post placement. So we visualized the root apices, we resected the root above it. Here you can see the radiopaque marker inside the post and the gatapacha. We removed that completely, curated the area. We retro prepped the area. This is the complete retro preparation, clean. Post was removed, retrograde. We placed the bioceramic material MTA retrogradely, and this is the post-operative radiograph. This is the clinical photographs, and this is the post-operative CBCT. You can see beautiful healing over here. So, to conclude this short lecture, only to remove enough dentine for successful disinfection is enough. We don't have to remove the dentine for obturation like we used to do previously for the warm vertical compactions. Only enough dentine should be removed as much as needed for the disinfection, which our recent bioceramic technologies and sealing abilities provide. Thank you.
Thank you so much, sir.
Yeah.
We are open to questions. If anyone have any questions, you can ask. You can write in the chat box.
Sir, in every case, we have to use bioceramic sealer or like which cases?
No, so doctor, for every case, bioceramic sealers can definitely be used right now. Reason being is its sealability is very good, solubility is less, and biocompatibility is good. So it is fairly okay to use bioceramic sealer for every case. I hope I answered your question.
Yes, sir.
Yeah, there's another question by Dr. Chaya, I guess. If I can elaborate how to know if we have to use MT or biodentine for perforation repair. So it is a operator dependent question completely. Like if like I personally prefer to use biodentine at times when I have to complete everything in single sitting. If there are multiple iatrogenic errors in a retreatment, like I have to remove file also and I have to do perforation repair also, then I prefer repairing the perforation first and then removing the file in the same sitting in the second half of that appointment. So I'll use a biodentine over there. But issue with biodentine again is that it has a very less radio opacity. It doesn't matter that much when we read about it, but when clinical scenarios and when we are judging the cases on follow-ups, this radio opacity matters a lot. So I use MTA when I have to complete the obturation and only one iatrogenic error is there, like just perforation is there, and I have to complete in single sitting, I have no issues in using MTA. But if there are multiple things to be taken care of in a single patient, I prefer using biodentine.
Sir, like in one case, you have used putty and then you have used the bioceramic sealer.
Yes.
So, in which case we have to do that?
No, yeah, exactly. Good question, Doc. So basically, that previously, what if we talk about the retrograde filling materials, initially, GIC was supposed to be used. After GIC, MTA came into picture, then MTA was used. After MTA, we came to know that we can reduce the osteotomy site, we can place the biceramic putty materials, and we used to place biceramic putty materials. Only with putty, what the issue is, if it is a class 1 cavity at the apex, there is frequently, like mostly, I have seen this, there is a gap in between the bioceramic putty, retrofill, and the GP. To remove that, we sandwich the sealer in between so the radiopacity is fluent and there is complete seal over there. Now, the advantage of using a putty on the head of the apex is that it has good washable resistance. It has good handling properties. It is a dense material, so it is not washed off easily. What happens is at times the sealer doesn't set by the time you close the flap of the patient. So we need something concrete on the apex of the tooth so that we are confident about the closure and the graft is not being mixed with the sealer which has been placed in the retrofilled cavity. So putty acts as a outer sandwich cover in that filling.
Thank you so much, sir, for this wonderful lecture. I think
Yeah,
so. We don't have any more questions.
sure, doctor. Thank you, everyone.
Thank you so much, sir.
Seal the canal three-dimensionally. Now, what are the ideal properties of an or the obturation technique should actually gain? First, it should provide a fluid tight seal. There should be adaptation to the canal irregularities. Minimum voids should be present, and it should preserve the apical seal. But till date, there is no single technique which is universally superior to all the other techniques. So we come to the objectives of obturation. What should be achieved while we are obturating the canal? First, as I already told you, we have to achieve a three-dimensional seal, prevent coronal and apical leakage, entrap the remaining bacteria. Whatever microorganisms are remaining in the canal after cleaning and shaping, they have to be entrapped and killed there. Fill accessory canals wherever possible and promote periapical healing. Now, what are the ideal requirements of an obturating material? Because an obturating material has to kill the microorganisms, first of all, it should have antimicrobial properties. It should be dimensionally stable. It should be biocompatible. It should not be toxic to the surrounding tissues. It should adapt well to the canal walls, be radiopaque so that you're able to see it, visualize it in the radiographs. It should resist dissolution. It should not be dissolved easily, and it should stay inside the canal. It should be easy to insert and remove. Suppose I have to go in for a retreatment, my case fails, and then my obturating material is not coming out, then that's also a problem. So it has to be easily removed. It should not discolor the tooth. There should be no staining of the tooth because of my obturating material. It should allow retreatment if necessary. Now, there are different obturating systems which are available, like your cold gutta percha technique, warm gutta percha technique, carrier based, and hydraulic condensation. So, today's topic we'll be discussing each one of them one by one. First, we come to the gold standard, which is the Schilder's technique, also known as warm obturation technique, which is warm vertical compaction. So, this was introduced by Herbert Schilder in 1967. And in this, we are actually heating the gutta percha. So once you heat the gutta percha is actually converted into alpha phase. So phase is very flowable as compared to your beta phase. This is a flowable phase which will go and fill your accessory canals, go into the canal irregularities, go into places which are very difficult to obturate. So this is a good phase which will have a flow property. So now here, how is it heated, the gutta percha? You have to heat it with an external source. So originally it was heated over an external flame like alcohol lamp, Bunsen burner. Now in modern practice, an electric heat source such as the touch and heat system is used to heat the endodontic plugger. This is the photo of a touch and heat system. You can see the plugger here, and this is heated. So first is master cone selection. As you know, it should have a tuck back. You should verify it radiographically. It should go up to your working length. So first you select your master cone. Then you place sealer. The sealer is placed inside the canal. And then we come to the third step, which is the down packing. So down packing, you have to take your heated plugger 4 to 7 mm short of the working length. So this heated plugger of mine, it goes 4 to 7 mm short of the working length. It softens my gutta percha because of the heat, because it has already heated the plugger. And then you have to apply pressure for some time so that your gutta percha cools and forms a dense apical plug. Here you can see this is my gutta percha going up to the working length. This is my heated plugger, which I have put it into the canal. You can see that I'm letting the 4 to 7 mm of the GP be there in the canal. It is going only till the top. And then finally, once I have applied apical pressure, I'm condensing the GP. Okay, so this is when the cooling is taking place and my condensation is going on. And these are compactors. So these are known as Schilder's endodontic pluggers. And with that, I'm forming a dense apical plug. So my apical plug is formed with a GP. My GP, which I have put, that was removed. The only 4 to 7 mm of the apical plug was maintained. The coronal GP from the middle third till the coronal end, it was removed with the heated external plugger. Okay, I had heated the plugger with an external source. Then now, because I have an apical plug there, which is with GP, but rest of my canal is empty. So now I have to backfill the canal. But here what I'm doing, this is the difference between continuous wave of obturation and compaction here. Here what I'll do is I'll again keep on heating my GP and incrementally add it. Okay, so this takes a lot of time and it has to be mastered. So the remaining canal is filled incrementally with heated gutta percha and compacted plug. It is used and compacted with pluggers until the canal is completely obturated. So what is the biological rationale behind this? That heating changes gutta percha from beta phase to alpha phase, which is more flowable, as I already told you. So once it is flowable, it will go and adapt to the dentinal walls intimately. It will fill the canal irregularities. The voids will be reduced and it will seal the accessory canals. My lateral canals also will be sealed with this. Advantages of this technique: excellent three-dimensional adaptation, superior filling of the lateral canals and the apical deltas, lowest void percentage. So my sealer, my GP, they are well adapted. There is less of voids. Obviously, the voids are less, the micro leakage will be less, the success rate increases, right? So there will be a dense homogeneous filling because my apical plug, the 4 to 7 mm of the GP, which I have left in the apical third, it is very well, it is condensed with the compactors, and this is well suited for complex canal anatomy. Now, there are certain disadvantages to this technique also, because this is, as you know, that you have to keep on heating, adding incrementally, you have to compact it. So you have to have a proper pressure. And this is a technique sensitive procedure. So not everybody can master it. You have to really practice on this. You just cannot do obturation with a warm vertical compaction. It is a time consuming method. As I told you, it is a longer learning curve. The risk of overextension is there if we are. Kindly mute yourself. Kindly mute yourself. So risk of overextension is there if the apical control is poor. You do not have an apical plug. So the GP which you are condensing with your compactor, it can go outside the apical barrier. So your constriction has to be there. So it cannot, you should have a proper constriction. And thermal shrinkage if vertical pressure is not maintained. I told you after heating, we have to maintain an apical pressure there on the GP because it is cooling. So this will compensate for the thermal shrinkage of the GP. If I do not maintain a proper pressure there, my GP, the shrinkage will be there, and then again micro leakage can occur. So what are the indications? Where should I use this kind of compaction, thermal compaction? First is in case of oval canals. As you know, oval canals, if I use a cold gutta percha technique, buccolingually, it will not fill. So it will leave voids in the buccolingual extensions. So warm gutta percha, as you know, it is more flowable. It keeps on flowing and it will fill these areas. So for oval canals, this kind of technique is very useful. For internal resorptive defects, because these are irregular cavities, they're large in shapes, so it is not easy to fill this with single cone technique, right? So my thermal, when I have heated the GP, alpha phase has reached, it is more flowable, it can go and adapt well to the walls. So internal resorptive defects are filled with this type of obturation. Here you can see C-shaped canal. There's a continuous C here. See, here if I fill with cold, if my cold GP is used, then it will not flow into the entire C. So it is best filled with softened gutta percha. So the entire C you can see here, it is well compacted. The GP is well compacted. And for C-shape, continuous C-shape, it is the best method to be used for obturation. Again, teeth with multiple accessory canals. Where are the multiple accessory canals? You have your maxillary molars, especially your mesial roots. You have mandibular incisors where you can have a lot of accessory canals present. Here you can see in the diagrams there are so many accessory canals. So once I start compacting my alpha phase of GP, then it starts flowing into these canal irregularities. So if you have multiple accessory canals, so this is the best method to be used. What are the contraindications where I cannot use this method? One is open apex because you are putting in a lot of pressure in case there is no, minor constriction there. There's no apical barrier. This tends to flow out of it, right? It can go out of the apex into the periapical region and cause more problems. So in cases of open apex, you are not supposed to use this kind of a method. If there is severe apical root resorption, because of root resorption, again, the apical anatomy of the root is not well maintained. Extremely thin roots. Why extremely thin roots? Because you're applying pressure. If the roots are very thin, they tend to have a fracture in them. Inadequate apical stop and inexperienced operator. Since this is, you have to keep on maintaining apical pressure, you have to cool the GP, you have to make a dense homogeneous mix, when to heat, when to add the increments, how much pressure to be applied. So this has to be with a lot of experience, one can master this technique. So inexperienced operators should also not try to do it. Now next, this under the worm obturation, we are talking the second technique, which is continuous wave of obturation. Now this is very much similar to the previous technique, which is the thermal compaction technique, vertical compaction. This was introduced, this is actually a modification of that technique, and this was introduced by Dr. Stephen Buchanan. Now what happened there was that we are actually heating the compactor, the endodontic plugger outside, externally, and then incrementally we are adding the GP and compacting it. Here what we are doing that we'll just heat the endodontic plugger itself is heated, and then we are just removing, we'll leave 3 to 5 mm of the GP, and with one continuous stroke we'll remove the coronal and the middle aspect of the GP. So you have a dense apical plug in one shot, and then on top of it you will fill the canal with a thermoplasticized injectable gutta percha. So this is a very easy technique to master. Also, it saves a lot of time and efforts. So it is a modification of the warm vertical compaction technique of Herbert Schilder that uses a heated plugger to compact gutta percha, and this happens in a single continuous movement. And the remaining canal is backfilled with thermoplasticized gutta percha. Injectable thermoplasticized gutta percha is heated up to 160 to 200 degrees, and it is injected into the prepared canal. So injecting the GP is faster. It is easier to master. You just have to press one button and take the gun out. So this is very easy to master. And the equipments used here for heating is system B, and for backfilling it is Obtura 3, or you can use a Calamus system for that. So this technique, it uses heat and pressure to fill the canals. Again, this is using a thermoplasticized GP. That means it is in alpha phase. So again, lateral canals, isthmuses, canal irregularities, apical ramifications, or are sealed. This results in a dense three-dimensional seal of the root canal system. First step, you have to select the master cone as earlier, then sealer application. Select the heated plugger. You have to select the heated plugger which will go inside the root canal till 3 to 5 mm of your working length. So this should not be binding to the dentinal walls, right? So you activate the heat source, which is system B. You heat this plugger, and in one continuous motion, applying gentle pressure, you will remove the rest of the GP and leave only 3 to 5 mm of the GP from the apex. Then you have to hold there for a few seconds for the GP to cool. And the rest of the GP is removed. You have a 3 to 5 mm dense apical plug. You verify this plug radiographically. So you see to it whether there are no voids. Is it compacted properly? Is it the achievable length 3 to 5 mm is reached? Then after verifying the apical plug, you backfill the rest of the canal with an injectable thermoplasticized gutta-percha. You can use an obturation system for this, or you can use calamus. And in small increments, you are putting it and taking the gun out of the canal. So with this, the canal is filled very quickly. This is your Buchanan pluggers, and you just leave 3 to 5 mm of the GP from the apex. Rest of the canal is not filled. These are the Buchanan pluggers, which are system B, and this is your obturation system. This is your calamus system. So what are the advantages of this technique? This is faster than your Schilder's technique. It also provides an excellent apical seal. There's good control of gutta-percha, excellent adaptation to the dentinal walls. It is a quick technique and useful for internal resorptions and irregular canals. Now, what are the disadvantages? There is higher risk of overfilling because it is a thermoplasticized technique, alpha phase, it is easily flowable. So then it can overflow. Okay, this also can shrink on cooling if not applied proper pressure. And it also requires a good apical stop. Otherwise, this also can go beyond the apex. Now, what are the differences? I talked about two warm techniques. One is warm vertical compaction, another one is continuous wave of obturation. So what are the differences between this technique? This table shows you exactly the same. First is in warm vertical compaction, we are doing multiple heating and compacting cycles. Whereas in continuous wave, you have a single continuous downpack. Then warm vertical compaction, because there is multiple heating and compacting, this requires a lot of time. It is time consuming, whereas continuous wave is faster. Warm vertical compaction is operator dependent. I told you you have to master in this skill, and this is more of operator dependent, whereas continuous wave of obturation is very simple. Once you have practiced on it, it will be very simple because of the gun, the injectable filling, later on backfilling. It is very simple to master. Then warm vertical compaction, you have to use repeated heating. Whereas here, in case of continuous wave of obturation, it uses one continuous heated movement followed by backfill. Now, the third warm technique of obturation is thermomechanical compaction. So first was warm vertical compaction. Second was continuous wave of obturation. And third is thermomechanical compaction, which was given by Max Padden, and it was given in 1979. So now why it is known as Max Padden's technique? Because it uses a Max Padden compactor. Again, a compactor is used here, but this compactor uses frictional heat. So this compactor keeps on rotating. So because of the friction, the heat is produced. And this compactor, it resembles a reverse headstone file. So I'll just show you the picture. See this. You have headstone file, which has a Christmas tree-like appearance of the flutes. Here, it is a reverse headstone file. So this is a Max Padden compactor. So once it rotates, this will keep on rotating at slow speed of 5,000 to 10,000 RPM. And this softens your gutta-percha. Because of the frictional heat, your gutta-percha melts. It is softened. And then because it is softened, it will fill your apical and lateral canals and obturate your canal. Now, what are the advantages because of frictional heat and the speed? This is rapid obturation technique, and it has good adaptation to the dentinal walls. Disadvantages, because it is rapidly moving, it is rotating, the frictional heat is being produced, there is risk of instrument separation. Okay, so the instrument, the reverse headstone file, your X pattern compactor can actually fracture inside the canal. There are higher risk of extrusion, and it is not much used these days because of your thermoplasticized injectable gutta percha techniques, which are even quicker to master, and they are very quickly you can fill the canal with them. So now we come to the fourth technique, which is carrier-based obturation technique. So carrier-based, you have a central carrier which is coated with your thermoplasticized gutta percha. So you have thermoplasticized gutta percha, but you have a carrier, okay, to hold this gutta percha. The carrier transposes softened gutta percha to the working length in a single insertion. For example, you have thermofill system, which has a plastic carrier, and gutta core, which has cross-linked gutta percha carrier. Now, what is the clinical procedure here? See, first you have to verify the size of the root canal preparation. So you have verifiers. You can see in this picture, we'll put these verifiers into the canal which you have prepared, cleaned and shaped. So according to your file, master file, we'll use the verifier size. Suppose I have prepared it 25.6%, then I use a verifier and I'll put it inside the canal. So this verifier, if it adapts well to the canal, suppose this is size 25, then I take a size 25 obturator. So verifier corresponds to my obturator size. So if the verifier is 25, I'll take 25 size. If it is 40, I'll take 40 size. Okay. So it will adapt well to your canal and it goes till your working length. So once I have verified this in the radiograph, I take an obturator with the same size. Now this obturator, you can see there is a carrier inside and the gutta percha is wrapped onto it. This is thermoplasticized gutta percha. So now I take this and I heat it in. This is known as thermoprep oven. This is for the thermofill system. You can see there are two slots. Okay. So I'll put this carrier, the softened part will be outside. The lower part, which is carrying the gutta percha, will go inside the oven. It will be heated to a temperature of 160 to 200 degrees Celsius. Again, it will plasticize. And that is when, and you will hear a beep sound. So once that beep sound comes, I'll take it holding the top, the stopper here, and I'll put it inside the canal. I'll verify with the X-ray that it has gone up to my working length. And then finally, once it has cooled down, I'll just cut this handle of it. Right? This has to be cut with a profi burr. A burr will be used to cut this handle. So the carrier and the GP, it remains inside the canal. So this is a very useful technique when you have very long canals, especially in cases of molars. When you have a complex anatomy, harder areas to reach, which cannot be reached normally. So this is very useful in that. Right? So I'll just go through the steps once. Selection, confirm the final sizing the root preparation utilizing a color-coded physical verifier. Verifier is, again, I'm repeating, is the size of the verifiers corresponds to the size of the obturator, which you'll be using for obturation. So heat the obturator inside a specialized thermoprep oven to yield optimal clinical fluidity. Insert directly to the length in a single movement. The carrier serves as a plunger guiding the gutta percha. Quickly cut off the handle at the canal orifice and compact gutta percha coronally. This is gutta core. See this, you are taking your carrier to your working length, gradually taking it till the end. And now because it has reached your end, I have taken a profi burr and I'll just cut it out till my cervical area. Okay. Till my cervical line, I'll just cut the carrier along with the GP from here and then condense it. So this is final obturation. It's just one simple technique. You have to definitely coat your canals with sealer first and then do this. And very slight amount of sealer is required for this. So it's a very quick technique. Once it's just heated into the oven, you're just putting it inside the canal and it is done. So what is the biological principle behind this? The flowing gutta percha adapts into canal fins, lateral canals, accessory anatomy, and oval extensions, while the carrier maintains the shape and position of the obturation. What are the advantages? It is a rapid technique. I already told you that it is very rapid because you just have to heat it and put inside the canal. So it is very quick. It has excellent adaptation to the dentinal walls. Less operator dependent than warm vertical compaction. Here, everything is just the carrier. If it is going till your working length, it will go and fill the canal properly. So it is not very very much dependent on the operator's skill. Predictable length control, useful in long curved canals, difficult posterior teeth, and narrow canals with complex anatomy. What are the disadvantages now? Difficult retreatment, especially with plastic carriers. Suppose I have obturated the canal with a plastic carrier, the thermophil system. Now, in case there is recurrent infection and I want to actually do a retreatment, it will be very tough for me to, take out the carrier from inside the canal. So then I'll use advanced ultrasonics and everything will be used. It will be even more time consuming. So it has difficult retreatment. There is a risk of possible carrier separation. Suppose my GP is, it strips out, it comes out, and my carrier also, it gets separated inside the canal. Then how am I to retrieve it? It becomes even more complex. It has higher cost, obviously, because you require the oven itself. Then you require these kind of specialized GPs, which are coated, the carriers, which are coated, verifiers you require. So the entire assembly is expensive. Potential stripping of GP from the carrier during insertion. Now, what are the indications? Where am I supposed to use this carrier-based obturation technique? As I told you, in long curved molars, the carriers facilitates placement of thermoplasticized gutta percha into complex curved canals. Busy clinical practice, suppose I want a very quick obturation technique which is accurate and not much dependent on the operator's skill and just goes, and I have multiple patients sitting. Then if you have a busy clinic, then this is a very quick technique to master. Narrow canals, the rigid carrier helps deliver softened gutta percha where conventional pluggers may not reach effectively. So this is a case which was done by gutta percha, this thermophil GP, the carrier-based system. Now, what are the contraindications where you cannot do this kind of obturation? One is your immature teeth, open apices cases because there's no stop. So again, you cannot use this. Very wide canals lacking resistance form, and teeth which are likely to go in for retreatments. Suppose you have a very big periapical pathology, you're not sure whether the treatment will last, will there be any flare-ups, So this kind of prognosis where is guarded, you should avoid teeth like that for carrier-based obturation system. So now to summarize, so this is all we are talking about: warm vertical compaction and warm techniques basically, where alpha phase of GP is being used. So in Schilder's technique, we have 4 criteria. You can see here, we have the heat source, vertical compaction, carrier based, and injectable. So Schilder's warm vertical compaction, it uses external heat source, as I already told you. Whereas Buchanan continuous wave, it uses heated pluggers. Injectable thermoplasticized gutta percha like your obtura and calamus, they use the heating gun. Carrier-based thermophil and gutta core, they uses the thermoprep oven. So these are the heat sources I'm talking about. Then Mex pattern thermomechanical compactor, it uses frictional heat. You saw the compactor and it was rotating, so it uses frictional heat. Now, vertical compaction, whether it is present in Schilder's warm vertical compaction technique, yes, vertical compaction is present. Buchanan's continuous wave of obturation for the apical plug, which you made for 3 to 5 mm, yes, it is present. Injectable thermoplasticized gutta percha, we do not do any kind of vertical compaction. Carrier base, we are not doing vertical compaction. Mixed pattern also, we are not doing any kind of vertical compaction because it is flowing on its own. Now, carrier-based system, carrier base is only present in case of carrier-based. You have the carriers and which are coated with the gutta percha, which is in case of thermophil and gutta core, which it is present. Then injectable for Buchanan's continuous wave obturation, the backfilling. Once the apical plug is created, the 3 to 5 mm, you are backfilling the canal. So for that backfilling, you are using injectable gutta percha technique. And again, you are using it for injectable thermoplasticized gutta percha. The entire canal, when it is filled with that also is backfilled. Now we come to single cone obturation techniques. So the traditional single cone technique relied heavily on large volumes of conventional sealer, leading to concerns about leakage due to sealer dissolution. So when we were using single cones with traditional, in conventional way with the conventional sealers, here with conventional sealer, I mean the sealers which are not bioceramic sealers, right? So there what used to happen, you had a single thin cone and you had a lot of sealer application around the cone, which used to fill the canal. So with time, the sealer used to dissolve. So now you had a lot of space inside the canal, micro leakage occurring, recurrent infection occurring, and finally the tooth failing, right? The RCT failing. So now with the introduction of matched taper gutta-percha cones and bioceramic sealers, this has changed into a concept which is now known as hydraulic condensation. So single cone, there are two types now. One is with conventional sealers, epoxy-based sealers, zinc oxide, eugenol-based sealers. These are conventional sealers. So there, the prognosis was not so good because the sealer concentration was more as compared to the gutta-percha concentration. Whereas now in cases when we are doing the single cone with bioceramic sealers, because bioceramic sealers, they are hydrophilic, they expand, they causes mineralization, they expand on, mixing. So this actually adapts well to the canal irregularities. It blocks the canals. So then recurrent infection doesn't occur so much, right? So there's prevention of micro leakage. There is good prognosis. It is comparable to your warm vertical compaction methods. So armamentarian matched taper gutta-percha cones, bioceramic sealer, which is now preferred. Lentillo spirals. Lentillo spirals are basically used for coating your canals with the sealer, and paper points. First step, as you know, is to clean and shape the canal. Dry the canal slightly. In case you are using a bioceramic sealer with a single cone, then you have to keep the canal a little moist because these are hydrophilic, right? So then you have to verify the master cone with a tuck back. You should take a radiograph here. Apply a thin layer of sealer. Insert the cone to the working length. You should not apply a lot of force. It has to be without pumping. And remove the coronal excess and compact lightly at the canal orifice. As I told you, the bioceramic revolution has come. It is hydraulic single cone technique. So historically, single cone obturation failed because conventional sealers dissolved over time, because a lot of sealer was there and it used to dissolve over time. Modern calcium silicate based bioceramic sealers are highly stable, hydrophilic, and they expand on setting. Dentin integration, how do they interact with the dentin? Interacts with dentinal fluids to form crystalline hydroxyapatite. Minimal technique sensitivity, simple, repeatable, and highly conservative preparation protocols. So this has actually revolutionized single cone techniques, the coming up of bioceramic sealers. So advantages, these are fastest obturation technique. Single cone with a sealer is very, very easy to master. It is a very quick technique to do. Simple and reproducible, minimal stress on the root dentin, does not, give a lot of stress because you're not compacting so much. You're not putting a lot of pressure. Conservative for minimal invasive preparations. Easy retreatment when an adequate gutta-percha core is present. And it has lower equipment cost. Now, what are the disadvantages? Highly dependent on the accurate cone fit. Your size has to match with the last file you have used. Less effective in large canal or irregular oval-shaped canals, right? I told you because oval-shaped, you will have a void buccolingually. It will not fill the voids buccolingually. Inadequate adaptation if excessive sealer thickness is present. Not ideal for extensive internal resorptive defects. Right? Because it will not flow to the resorptive defects. It will not cover the entire area. There will be a lot of voids which will be present. Now, what are the indications where we go in for single cone techniques? One is your round canals. Round canals, they are very easy to actually obturate because once you have a matched taper cone, then it will fit entirely to the circumference of your canal and the canal is obturated in one go. Minimal invasive endodontics, if you're not actually preparing a lot of, access cavity is minimal, your preparations are minimal, then you have space only for very, slight cones to go. So one single cone obturation is sufficient. So no additional space is required for the pluggers, nothing. So you have a minimal preparation. You cannot put in pluggers which are of bigger sizes. So it is good to go in for single cones. Routine primary root canal treatments, when you are routinely treating patients in the clinic, doing things which will require a lot of time, lot of efforts, lot of money is not possible. So then you can go in for single cone techniques. Bioceramic sealer protocols, hydraulic condensation is specifically designed for modern calcium silicate based sealers. In case you are using them, again, you have to go for single cone technique. What are the contraindications now? I already told you cannot use them in wide oval shaped canals because they'll not fill the entire circumference. There will be voids and it will not adapt to the canal irregularities. So a lot of space will be there, which will lead to micro leakage, recurrent infection, and finally failure of your root canal treatment. Then internal resorptive defects, you cannot use them. C-shaped canals, when you have a continuous C, you have to fill in the circumference. You cannot use these things because they will not flow into the entire geometry. Inadequate cone adaptation, if the size is not matching, the taper is not matching the canals, then you should not use it. Large accessory spaces require thermoplastic flow. If you have a lot of accessory canal anatomy, obviously you will have to use something which is flowable, okay, which is thermoplastic. So you will have to use alpha phase of gutta percha here. So you cannot go in for single cone techniques here. So now we compare the parametric comparison of all these techniques. So first is your primary principle, okay? So primary principle for warm vertical compaction, you are actually vertically compacting the softened gutta percha. For carrier base, it is oven heated pre-coated solid carrier, which is there. For single cone and bioceramic, you have hydraulic sealer push. So hydraulic, why we call it hydraulic? Because the sealer has this push, it is pushing it, right? Now you have anatomical adaptability. Obviously, warm vertical compaction, I told you it is the best. It has excellent three-dimensional filling. Carrier base also has an excellent three-dimensional filling. And if you use single cone along with bioceramic sealer, it has very good adaptation to the canal walls. But if you use single cone with epoxy-based sealers, or if you use with zinc oxide eugenol-based sealers, definitely it does not have good anatomical adaptability. Then micro leakage risk, warm vertical compaction is extremely low. Carrier base, it is low. And with bioceramic sealer and single cone, it is extremely low because they expand on setting. Technique sensitivity, warm vertical compaction is highly sensitive. It is operator dependent. Carrier base is moderate. And single cone with bioceramic sealer, it is very simple to master. It is reproducible. So technique sensitivity is low, right? Retreatment difficulty, I told you the carrier base is the most difficult to retreat. Okay, so it is difficult because of the plastic carrier. You're not able to bypass the carrier. Whereas in warm vertical compaction, it is moderate. And with single cone, with bioceramic, if the GP is bypassed, it is very easy. With normal sealers, it is extremely easy. Then core equipment cost, you have high cost in touch and heat system when you are using warm vertical compaction. You have moderate cost with thermoprep oven in cases of carrier-based system. And single cone with bioceramic and normal your sealers, it is conventional sealers, it is low. Warm vertical compaction, the best feature is that it is the gold standard for three-dimensional obturation and adaptation. Main limitation is highly technique sensitive and equipment intensive. Carrier base, it is rapid and homogeneous filling with good adaptation of the dentinal walls. Here, the limitation is the retreatment is challenging because the carrier, to bypass the carrier is difficult. To take out the carrier, retrieve the carrier back is even more difficult. Single cone obturation, it is simple, quick, and cost effective, which is the best feature. But in case you are using conventional sealers, then it relies, just a second. Okay, it relies heavily on the sealer and may not optimally fill canal irregularities, right? So if your sealer, the amount of sealer is more, with time it will dissolve and this will not give you a good result in future because micro leakage will start. Now, in cases when we compare your adaptation to the canal walls, the voids, micro leakage, and in cases of retreatment, how are these techniques actually serving? So we'll compare all the four together. You have warm vertical compaction, adaptation to the canal walls is excellent. Why it is excellent? As I told you, it has alpha phase of gutta percha. It is flowable, so it will go and adapt to the canal walls. It will reach irregular spaces. It will reach areas which are difficult to reach, right? And the voids produced here, they are the lowest. Okay, it will not produce a void because it has a dense homogeneous mix. Now micro leakage is also lowest because there is a dense plug which is there. There is adaptation to the dentinal walls, so obviously the micro leakage will be less. Retreatment is moderate. Okay, the difficulty in retreating is moderate in cases of warm vertical compaction. For carrier-based, you have excellent adaptation to the canal walls, very low voids present, very low micro leakage, but retreatment here is difficult because to retrieve the carrier, to bypass the carrier is difficult. Single cone with epoxy sealers. Epoxy sealers are your AH plus and all these sealers which we are using. Adaptation to the canal walls is moderate. Okay. Voids are higher because with time, over a period of time, it will dissolve and it is not well condensed. Then micro leakage obviously will be high, and retreatment is easy, but here, okay, the retreatment possibility, because you just have to take out a single cone, right? So it is very easy here. Single cone with bioceramic sealer, it has good to excellent adaptation to the canal walls. Voids are low because it expands and it mineralizes, so the voids will be less. It is the micro leakage is comparable to warm techniques in many studies, and the retreatment is moderate because it mineralizes, so it is not so easy to be taken out as compared to your epoxy sealers or zinc oxide eugenol sealers. But yes, it is easier as compared to carrier based, right? So to summarize, which canal anatomy, which method, which technique should you prefer? So the preferred technique and the canal anatomy. For round canal, you should have single cone with bioceramic sealer. This suits it best. Oval canals, warm vertical compaction, because I told you oval canals, they have a larger circumference, buccolingual extension needs to be filled, which is very difficult in case you are using a single cone technique. Internal resorption, warm vertical compaction again. C-shaped canal, warm vertical compaction. Multiple accessory canals, warm vertical compaction. All these, they require lot of sealing, lot of space to be filled, lot of canal irregularities, and no void should be present. So for that, warm vertical compaction remains the best. Long curved canal, you should have carrier-based obturation technique because it is easier to reach there. Minimally invasive shaping, then you should go in for single cone and bioceramic sealer. Difficult molars requiring speed. When you require speed and they are posterior teeth difficult to reach, then you can use carrier-based obturation technique. So now the current scientific consensus is warm vertical compaction remains the gold standard for achieving the most homogeneous obturation and best adaptation to the canal irregularities. Carrier-based obturation systems provide sealing ability comparable to warm vertical compaction while being less technique sensitive. Single cone obturation with conventional sealers generally exhibit greater micro leakage. Single cone obturation with bioceramic sealers has shown sealing ability approaching that of warm obturation techniques and is increasingly supported by contemporary evidence. So this is according to systematic micro CT evaluations, and the percentage of void and the sealer thickness inside the apical 3 mm of the canal has been noted. So you can see that warm vertical compaction is 1.5%, carrier base 1.8%, so not significantly different. And you have single cone bioceramic approaching 2.2%. Okay, so this is almost comparable to your warm techniques. But when you use single cone with epoxy sealer, you see here that it is 7.8% of the voids are present. So this is the void percentage which is in the apical 3 mm of your sections. And this is why, because it has dissolved over a period of time. So these are almost comparable, right? So finally, coming to the scientific conclusion, warm vertical compaction remains the definitive standard for sealing complex, irregular root canal spaces. However, the hydraulic single cone technique using modern bioceramic sealers is highly efficient and offers excellent sealing ability in minimally invasive preparations. Ultimately, clinical success is driven by proper diagnostic selection, carefully assess the canal anatomy, thickness of the residual dentin. Why do I say thickness here? I told you if you have very thin canals, you do warm vertical compaction, there can be fractures in the root, right? So you cannot go in for this kind of a technique there. So you have to see to the thickness of the residual dentin as well. And future restorative needs can be retreatment if required. If there is any other things which has to be done to retreatment, then do not go in for carrier-based obturation, right? So needs to determine your obturation method. These are my references, and thank you for your patient listening.
Thank you so much, ma'am, for such wonderful lecture.
Most welcome. Thank you.
Any of the delegate, if they have any questions, they may please write in the chat box. We are open to all the questions.
Any questions from the audience? I think they all understood well.
Thank you, ma'am, for the wonderful lecture.
Thank you so much for giving me a chance and inviting me. Thank you.
Dr. Shubham, we can proceed with the next lecture.
Next, we have Dr. Nishi Jayasin, ma'am. She is Associate Professor, Department of Conservative Dentistry and Endodontics, Yenovaya Dental College.
Good afternoon, everyone. I'm Dr. Nisha Jayasin, in the Department of Conservative Dentistry and Endodontics from United Dental College, and I'm here to talk on how to save your rent. I'll be dealing on overlap, post and pull as intro. So now, first, let us understand what are the biomechanics of the endodontically treated teeth. All of us know that an endodontically treated teeth is different from a vital tooth. How so? In composition, the collagen structure is lost. It increases the tooth fragility and reduces the addition to substrate. The dentin structure, as said, the elastic modulus and the behavior is drastically reduced, which increases the tooth fragility again. The tooth microstructure is so compromised, there is a resistance to deformation, resistance to fracture, and resistance to fatigue, thereby reducing the retention and stability of a prosthesis. But this is not all that contributes to it. It is more or less the amount of tooth lost during your access cavity preparations. So this is the reason why during access cavity preparations, we lose a lot of the pericervical dentin. A lot of tooth structure is lost. Hence, there is modifications towards preserving the pericervical dentin and ensuring there is a good good resistance by the tooth itself to tolerate the forces. Now, how has the paradigm shift happened? The paradigm shift is towards the minimally invasive procedures has occurred due to the increasing research in adhesive dentistry and the modern materials and the conservative cavity modifications that has come in. So let us see what is this paradigm shift. This is done to preserve the sound tooth structure, to maintain the critical area to ensure there is a proper ferrule, the use of adhesive systems to reinforce the remaining tooth structure so as to match the dentin modulus, so that we get materials which are almost having similar properties to natural dentin. Now moving on to the components of root canal treated tooth. So there is an obturated tooth. You can have a post within it or just a co-buildup and it is topped up by a prosthesis. Understand this concept. The function of the root is to just retain the post, whereas the function of the post is to retain the core. And it is the core that retains the crown. So always understand before you reduce the tooth structure that is remaining, do you really need to rely on the root, the post, or the core for your final prosthesis? Most of the endodontically treated teeth are lost due to poor restoration than the subsequent endodontic failure. That is, even if your endo is actually done very well, there is a beautiful endo done. It's having a 3-dimensional obturation seal, but it can always fail because it is not restored well. There is no proper coronal seal. The restoration is leaky. The prosthesis is not designed well to resist the forces acting on it. It will definitely fail. So what are our objectives that we should look into if we're trying to save our endo? First and the foremost is to prevent any kind of microbial leakage into the root canal system. You have to restore the tooth back to its form and function. You have to restore the aesthetics. The tooth should be restored in such a way that it is easy to maintain the health of the tooth and the surrounding tissues. You need to make sure whatever planning that you're doing to restore your post-endo treatments, it should protect the residual tooth structure. So before you begin anything, always have the end in mind. So before you start with your endodontic treatment, you need to assess or imagine what kind of a post-endo restoration are you planning on giving for this tooth. So you start with an endodontic evaluation. See if the tooth can be saved first, or before you're going into your post-endo restorations. How well do you need to do your endo? Is the endo already compromised? Is the if the patient has come to you after RC treatment done from elsewhere, you need to evaluate the endo, the part, how it is done. Is it already leaking? Is there a lesion? Is it so compromised that you need to redo it or not? Then you go ahead with the periodontal evaluation. Is the tooth sound? Can it withstand the forces which is going to face in the oral cavity? Is it strong enough to receive the processes and take the load? If not, you have to go in for a periodontal intervention. The biomechanical evaluation means checking out the occlusion, the tooth and function. Is it functioning well? Does it have the strength to take up the load? Is it the occlusal forces are being directed just to that tooth? Is there any other adjacent teeth that are missing? You have to pre-plan all of those things. And final and the foremost is the aesthetic evaluation. When the patient smiles, it has to look beautiful. So this is a way of deciding what you're supposed to do. So if it's an endodontically treated tooth, you're going to assess the remaining structure. Do you think you can achieve a ferrule? If well, fine. Then you don't need to go in for a post. You can go in for a direct composite core and then establish a ferrule, and you can go for a more definitive restoration. No, the ferrule is not achievable. There is an inadequate tooth structure. Then you need to think of a custom post or go for something like a endo crown. Here again, the ferrule is the most important point. So how do you decide whether the tooth is restorable or not? You take a perio probe, measure the height of the tooth. You should have at least good 2 to 3 mm sound tooth structure remaining before you can think of restoring it. Whether do you cap it, do you preserve the tooth structure, or you reduce it down to size. You take a vernier caliper to measure the thickness. So you have to go deep into the base of the cavity prep and check the thickness. So for molars, as a rule, it should be at least 2.5 to 3 mm. For premolars, you can get away with 2 to 2.5. But you need to measure the remaining tooth structure. If the thickness is less, you need to decide on what kind of restoration you're going forward with. So understand that as in you reduce the tooth structure, the function of the tooth is compromised. The ability of the tooth to withstand the force is compromised. So the more tooth structure it loses during your cavity preparations, during your caries excavation, during your modification of your access cavity designs, it is gonna drastically compromise on the fracture resistance of the tooth. So always analyze this before you go ahead. Before you start your endo, the most important thing is to do a pre-endo. That is ensuring there is a ferrule present even before you finish your endodontic treatment. This can be done by doing a marginal elevation technique, a donut or canal projection, or in case you're not having sufficient ferrule height of 2 to 3 mm, you can always go in for a surgical or orthodontic extrusion or an apically positioned flap with bone resection. So this is how you do a cervical margin relocation. You have to isolate the tooth well, make sure that you place a suitable matrix to engage the cervical portion that you're going to raise up, and then use bulk fill or any kind of flowable materials to slightly raise the margins so that a ferrule is formed. You can also do a canal projection technique wherein you locate the canals, you finish your mechanical preparations, you place the GP within it, and then build it up with any composite core. So this ensures that the forces are distributed equally, and the tooth, when the patient comes back for your next visit, patient will not come back with a broken tooth structure. This is another technique wherein you kind of seal this chamber and then build a restoration around it. This is called as donut technique. Excuse me. So endodontically treated teeth, if it is a class 1, do you need to always go in for a post? No. You can go in directly for a composite restoration if provided the remaining walls are sufficiently thick. The thickness of the walls are very crucial here. If all the marginal ridges are present, you do not need to go in for a core buildup, a post and core technique. You can directly go in for a direct. You don't have to go in for a cuspal coverage either. If it's a class 2 cavity preparations, you can choose. You can either do just a direct composite restoration, evaluating the remaining tooth structure, or else you can go forward with an indirect restoration like an inlay or an onlay. Both these cases, cuspal coverage will be based on the remaining tooth structure. So this is a class 1. So here you can see how there is a good bulk of tooth even in the deepest portion of the cavity. There is a good 2 to 3 mm or more than that in around surrounding the tooth structure. So in this case, you can just directly go in for a composite restoration by a layering or oblique layering technique and then finish it off. This should suffice enough. But now, the question that you would ask is, even if you do this, some patients come back with a cracked tooth. There's like all the 4 walls are there. Still, why has the tooth fractured? Okay. One of the reasons is you have not assessed the thickness of the tooth. If the tooth thickness is less than 2, that cusp will eventually fracture. Why? It does not have the strength to withstand the force. The second thing that most of us overlook is a graze line or a crack line which is seen. So if you see in this picture, you can see there is a graze line. But here you would think that you will just go with 4 walls are intact, that is sufficient thickness of the tooth. There it's more than 3 to 4 mm. It should be fine, right? No. If there is a crack on the tooth, you have to go ahead with a crack dissection procedure. You have to dissect the cracks. You have to make sure the crack propagation stops. If you do not do this during your evaluations, this is definitely going to fail. The patient will come back to you with a vertical root fracture. These are one of the few things which most of people overlook. Okay, so these are things you need to identify during your preparations. So what all restorative materials can you use? You have a choice. Okay, you can use either a nanofill, you can use a smart dentin replacement, you can use bulk fill, or you can use your fiber reinforced composites. So how do you decide which to use where? Okay, so your normal cork buildup materials, they can be used in any high compressive fracture strength. It has, okay, so it can be used as a core under a crown. Okay, your core buildup materials are designed in such a way that they can give support to the core when it is placed under a crown, right? Now, bulk fill restorations, they have moderate to high fracture resistance. So they are generally a little lower when you compare to the dedicated core buildup materials or the fiber reinforced materials. They can be used in high stress situations, but then most of the time you need to layer it up with the indirect restoration. Okay. Now, your fiber reinforced composites, they are having a high fracture resistance. They have shown improved fracture resistance when you compare it with your co-build-up materials and your bulk fill materials. And they can be used in large restorations. So whenever you need, when you feel the tooth is more compromised, you need more strength, go in for a fiber reinforced composite. Okay. Now, the problem is with co-build-up materials is that they do not have ideal aesthetics. So they cannot be used as a final restoration. You have to layer it up with a crown or a prosthesis, right? Whereas bulk fill materials, they can, you can fill it up to 4 to 5 increments, all that, but it does not have a good finish. So this also has to be layered with a nanofill composite, or else you have to use a indirect restoration. These are exceptionally good when you have to restore a extremely deep box, okay, because when it is beyond the recommended cure depth, right? Whereas for fiber reinforced composites, they have, you can use them for patients with who are heavy bruxes. They have deep bites. They have an unfavorable occlusion. You need more, there's going to be more stress being put on that particular tooth. If like it's an abutment for an FPD and all those kind of things where you need more resistance to fracture, where you need the core to take up more of the load. The core is taking up the load, okay? It's not the root or the post. It is the core that is going to take up the load. So for this, you can use fiber reinforced composites. Now, when you move on to endodontically treated tooth, you have something called as a class 2 MODs. You can always go either for a endocrown or a post-in core and a PFM crown. So it is based again on the tooth structure. You're going to decide which you're going to go for. Okay, so for all this, you will definitely need to go in for a cuspal coverage, either by any of the indirect restorations, or if the tooth is severely compromised, you might have to go in for a crown. So these are the different types of indirect restorations which are currently being used. You have an inlay, you have a tabletop, a veneer lay, onlay, overlay, or an endochrome. Now, as you see, all these indirect restorations are preserving the natural tooth structure as much as they can. So they are designed to be used in compromised cases. Okay. So now moving on to the preparation design. Now it is more of aesthetics. So the preparation designs and the clinical protocols have slightly changed. So they are more of a slot bevel and a rich preservation preparations. So, excuse me for a second. Sorry about that. So, really sorry about that. So now as earlier, the guidelines are for a full occlusal coverage, where like for the palatal or the lingual cusp, you can simply reduce it by 2 to 3 mm by butt joint. Now you have, whereas on the buccal cusp, you have 3 options. You have the ultra conservative buccal cusp coverage, you have the conventional buccal cusp coverage, or the full buccal cusp coverage. Now, the full buccal cusp coverage is indicated when aesthetics is a concern. You need to the tooth is in the area of the smile, like when the patient is smiling, the tooth is visible, you need to go in for a full buccal cusp coverage for aesthetics. The other two, depending on if the patient is okay with, if you can get away with a little bit of the onlay junction showing, then you can go in for the the conventional buccal cusp coverage. The conservative preparation is a little bit better as it stops at the end point. Excuse me. Now the concept has changed into a morphology-driven preparation technique. Now this is guided by the location of the dental defects, the natural geometry and microstructure of the tooth. They rely more on a hollow chamfer or a butt joint. So the slip joints are more or less placed to ensure that the tooth can slide in properly. Like the fit, it will facilitate the seating by providing a precise path of placement that allows single or multiple units. Now, this also opens up the cable surface angle to a greater than 90 degree, creating a fine terminal edge. Whereas the hollow chamfer, it is applied as a continuous inclined plane on the axial and buccal and lingual walls when margins are located coronally to the height of contour. Whereas the butt joint or a rounded shoulder, a 1.2 mm prep, is utilized in the interproximal boxes or on axial walls when the margins are a defect and when they're extending apically. Now, if you see here, when you give the hollow chamfer, it gives a more favorable, it's more favorable for addition. So that through the cut enamel, the hollow chamfer preparation, they are favoring addition much better when you through the cut enamel prisms. So now these are the preparation. So the slot preparation is a rounded shoulder of about 1 mm. The bevel is a less invasive prep when compared to the slot without going too deeply into the cervical bevel. The ridge up type is the ridge preservation or the ridge coverage. So the ridge preservation will allow for maintenance of the integrity of the marginal ridge, whereas the ridge coverage allows for minimal surface preparation, thereby preserving the contact area. So to summarize this, the minimally distracted teeth, you can go for an intracoronal composite resin restoration, whereas a moderately distracted teeth, you can go in for a overlay or any of the indirect restorations. Whereas a severely distracted tooth will need a fiber post and core crown or an endo crown. Now these will be depending on any of these variations. Any of these restorations, you will have to modify it based on the parafunctional habits, the lateral or crucial forces, or if there are less than 2 proximal contacts. So now let's move on to the classification of the teeth with extensive endodontic damage. So class 1 is having a good prognosis. Class 2, wherein the extensive damage is more, it is more of prognosis is moderate, whereas the class 3, it is poor. So this is how you determine under which class the tooth is going to fall down. So you have to measure the ferrule, you have to measure the root length and the endo. So what exactly is a ferrule? So ferrule is nothing but a three-dimensional structural band with height, thickness, and circumferential completeness. And all these 3 dimensions are independently will affect the fracture resistance. So this is the 3D ferrule, which was coined by David Clark and Katini. So ferrule has 2 parts. One is the core ferrule, which is gonna engage the core, and the crown ferrule, which is gonna engage the crown. So it is like people promote a lot of posts that this post has this design, that favor, this favor, yes. But understand that post is important, yes, but the ferrule is more important than the post. So if you can't obtain a good ferrule, your post is not gonna save your tooth. So what is the actual purpose of a ferrule? Okay, the purpose of a ferrule is to improve the structural integrity of the pulpless tooth by contacting the functional lever forces, the wedging effect of a tapered dowel, and the lateral forces exerted during insertion of the dowel. So if there is no ferrule, the forces will fall obliquely on the tooth and there is going to be more of a root fracture. Now that we have understood ferrule, now we'll move on to the monoblock concept. So the monoblock concept is defined as the creation of a solid bounded continuous material, okay, from one dentin wall to the canal to the other. Okay, so what basically it means is that you're just making a homogeneous unit with the root dent. So you have a primary monoblock wherein there is just the filling material, the dentin and the cementum. There is just one single circumferential interface. So that can be obtained by using Hydron MT or any kind of polyethylene fiber post. Now, the secondary monoblock is wherein you have 2 distinct circumferential interface. One is a cement, one dentin, the other between the cement and the core material. Whereas tertiary is introduced between the bonding substrate and the abutment material. Now, let's go into the different types of post. So you have a custom-made post and a prefabricated post. So you have metal ceramic, metal carbon. Let's take a comparison between what is what, okay? So when you compare fiber post with metal posts have a higher stress concentration. They're more of active posts. So wherever you put, there's a amount of threading that is in place. So it will ensure there are crease lines or crack lines which are formed into the dentin. This will propagate eventually. That is why there's a higher risk of fracture in metal cast posts rather than a fiber post. So most of the failure patterns in fiber posts are favorable when compared to any other cast post design. The stress location is towards the cervical region due to the flexibility of the fiber post, whereas for metal, it is more at the post-dentin interface. That is why you see more of root fractures when you're using a metal or a cast post. So, whereas when you compare it with zirconia post, you have a 5 times greater stiffness than the fiber post. But here the problem is similar to the metal post, they have more of catastrophic root fractures. So you cannot save the tooth, it has to go for extraction. Whereas in fiber post, most of it is towards the cervical part of the tooth so that you can still salvage the tooth. So now moving on to the classification of fiber-based post, it can be the carbon fibers, silica fibers, or polyethylene fibers. Now, there are different factors that affect the post and cone. So you need to understand at what post can you use for what type of tooth. Now, these are the determining factors. So you have to see the post length, the post diameter of the width, the post shape, surface structure, material, the core retention, the canal configuration, coronal tooth structure, and what forces are acting on the tooth. Now, if the post length is more, okay, the better the retention and the stress distribution. So it's always advised, if you're especially going for a cast or a prefabricated post, preserve around 4 to 5 mm of apical GP to maintain the apical seal. The post length should be equal to the length of the crown or 2/3 the length of crown, whichever is greater. So now, this is what I said earlier. For metal post, which is a non-adhesive cementation, okay, it's more of a mechanical retention, you have to extend up to 2/3 of the length canal. For fiber post, where you're relying on more of adhesive cementation, you can go at least 1/3 to half of the length of the canal. Now, root canal anatomy will dictate the post selection. So depending on the width of the tooth, the size of the tooth, the variations in the anatomy, you're going to decide if you need to place a larger diameter post or a smaller diameter post. Now, this is a post diameter philosophies which has been proposed: the conservationist, the preservationist, and the proportionist. So conservationists say that you have to preserve as much as root tendon as you can. The preservationists say that around the post should be at least 1 mm of root tendon surrounding it. The proportionists say that there should be equal amount of root tendon surrounding the post. These are the recommended post widths for the incisors, canines, premolars, and molars. Now, if based on the canal, if an extensive preparation is required, you can always opt for a well-adapted cast post or an anatomic post. Tapered custom cast posts are recommended only in canals with the irregular anatomy. The post designs can be parallel tapered or parallel tapered. The parallel tapered posts are least, they distribute. They are more recommended because they easily distribute the forces. The post width, you have to decide based on how much of tooth structure can you preserve. You have to always keep in mind chance of perforation, and you see if the remaining tooth can resist the fracture. A passive post is always recommended than an active post because of the tendency to propagate cracks and fracture the tooth. So now let's look at how a post and core is done. So you start by removing the obturative material, then finish it off to the desired length of the post. Etch the tooth surface, wash it off, dry it. You can use paper points to dry within the pore space. A suitable bonding agent is applied and then light cured. Always the excess bonding agent has to be removed from within the pore space by using a paper point, following which a core buildup material is added into the canal, a fibrous is placed, and then it's cured. It is always advisable to prepare the post earlier before cementing. Okay, so cut the fiber post according to desired height before you cement it into the canal. Then the whole core buildup can be done. And one important point to be noted is that the post should never be exposed during your preparation. So make sure that there is sufficient space for your core to hold on to your post. So these are the traditional loading cements which are there. So you have your traditional cements, you have glass enamels, resin based, and cell adhesive cements. So how do you select them? So if you're going for a non-metallic post, it's better to go for something with a GIC based, a resin modified GIC based luting cement. If you're going for non-metallic post, dual cured resin cements are recommended. For zirconia, it is better to go for a resin cement containing functional phosphate monomer. Moving on to the core, you have a cast core or a plastic core. And so you have even composite glass cores, anything can be placed. So there is something called as ever-stick post which has come in, which kind of can be used as a short post. It has a high flexural strength after light curing. So this is how it is done. You measure the length of the root canal after preparation of the post base. So this can be used in where there is a variation in anatomy where you can't go in for a traditional fiber post or cast post or custom post. These kind of help in those kind of difficult anatomies. So you measure the length, you start application of the etchant. When the etching gel is done, you apply the adhesives, remove the excess adhesives, slide cure it. Then you're going to use DentaPreg. You cut the strip according to the measured root length. Now, the scissors that is being used are very sharp. So they are designed in such a way that they do not damage the fibers much. Okay, so it's advisable to taper the strip and then you adapt the strip into the root canals and you can keep adding layers as you want it. Once it is done, you're going to apply the cement into the root canals and onto the strip. Then you are inserting the strip into the root canals. You remove the excess overflowing cement, then light cure the cement. And there you have your short fiber post. Okay. So now moving on to what kind of temporary restorations can you place? So depending on the coronal structure, if it's minimal or weak, how long do you need to keep it? So if it is less than 2 weeks, you can go for cavity or GIC shell. You can go for, if it is more than that, you go for a base acrylic crown. If it is more than 8 weeks, it's preferred to go for a reinforced or milled crowns. If the tooth structure is moderate, it's almost similar. You can go on for an only or overlay as instead of a crown for base acrylic. After you place the temporaries, you adjust the occlusions, you check the contacts, the margins, the seal, give instructions to avoid sticky or hard food, and then you schedule the patient for a definitive restoration. So now let's see in temporization. So you have direct or indirect methods of fabrication. You direct for long term and or short term, you can use it. You can either make it custom or you can get it preformed depending on the different types of materials. Okay. So these are the commonly used direct restorative materials as ProTemp and or Revotec. And these can be cemented with temporary luting cements. So this is how to show. So once once you connect it, it is always important to bleed the excess material. Then you have to make a mock-up of the tooth that you're going to give a temporary to, or else take an impression before you do your prep, and then into the silicone index, you're going to inject slowly the ProTemp material without any voids or air bubbles, and then place it back onto the patient's tooth of interest. Hold it in position till the material sets. Once it sets, you have to slowly remove it out from the impression material. It is pretty thin at certain areas. So make sure that when you remove it, you do not apply too much force. You use a blunt instrument to slightly remove it from the impression material. So once you get it, you wipe off the uncured resin from the margins. Then go ahead with the polishing, reduce any sharp contact areas which is there, margins which is there, polish it, and then check the fit in the patient's mouth. Check for occlusion, see if any corrections has to be done. This is a very important step even when you're doing provisionals. Now once occlusal check is done, it's all checked and correct. Sorry. Once it is done, you can always apply the temporary cement, mix it up, apply it into the cavity, place it onto the tooth of interest, hold it in position, remove off the excess. You can always keep floss on the side to remove it off, and then you can always also go in for, if you're going with Revotec or a direct technique wherein you adapt the composite directly over the tooth as a temporary, you can use something called a spot etching. So you just spot etch using phosphoric acid only in one point, apply a spot bonding agent, light cure it, and then you make a direct temporary and then place it on the tooth and cure it. So understand that even if you do an absolutely beautiful RCT, if you do not do a good post-endo restoration and definitive prosthesis for it, there's going to be a failure. In some cases, if you're lucky, even if the root canal is not that great, even if you give a good post-endo restoration, it can be still successful. So understand that micro leakage is the silent killer here. So no matter how beautiful you make a crown, if the foundation of it is not strong, everything else is just gonna topple down. So always begin with the end in mind. Before you start with your endo, have in mind what kind of a post-endo restoration are you going to give for this patient. So with that, these are my references. Thank you for this opportunity.
Thank you so much, ma'am.
Thank you so much.
If any of the student has any doubt, you can ask. Ma'am is with us only. I hope everything is clear to everyone. Thank you so much, ma'am, for such a wonderful lecture.
Thank you so much for the opportunity.
Thank you so much, everyone. We are done with the day one of the Endo Mastery Summit. We'll be continuing tomorrow at morning, 9:30 a.m., starting with our first lecture for the day two of the Endo Mastery Summit. Thank you, everyone, for joining us.